Good morning, distinguished keynote speakers, poster presenters, respected delegates, and esteemed participants joining us from the globe. It is my great honor and privilege to welcome you all. It is my great honor and privilege to welcome you all to this prestigious Emirates Pathology Digital Pathology Conference and exhibition. On behalf of the organizing committee, I extend a warm greeting to every attendee who has taken the time to be a part of this important global gathering. Today marks not just the beginning of a conference, but the launch of a truly collaborative platform where knowledge, innovation, and expertise come together. This event reflects the spirit of international collaboration, bringing together experts from diverse fields, including pathology, digital diagnostics, cancer research, and broader healthcare and disciplines. Together, we aim to share valuable insights, cutting-edge research, and practical advancements in pathology, digital pathology, and cancer care that will contribute to improving diagnostic accuracy, enhancing patient outcomes, and shaping the future of precision medicine. I am Dr. Batul Ahmed, and it is my pleasure to serve as your chairperson for this session. I look forward to an engaging, inspiring, and highly productive day together. Utilitarian Conferences Gathering is a leading global platform dedicated to organizing high-quality professional meetings, conferences, workshops, and symposia. With a strong focus on medical, clinical, healthcare, life sciences, and pharmaceutical fields, UCG effectively bridges the gap between academia and industry through innovation, collaboration, and excellence. With a global reach, 24/7 support, and a highly committed organizing team, UCG ensures that every event is impactful, well structured, and tailored to meet the evolving needs of its participants. On behalf of UCG, I extend my heartfelt gratitude to our organizing committee, distinguished speakers, and all participants who have contributed to making this gathering a success. Together, we are driving progress and shaping the future of healthcare. Ladies and gentlemen, our first speaker is Mrs. Lisa Roos, PhD, Oncology Humanitarian and Project Lead, Green Bereavement, joining us from Germany. She will present on the future of cancer care for cancer patients with regard to necessary research and stable support in a time of global political pressure, how we could foster a stable environment. Kindly join me in welcoming her.
Thank you. Good morning. I hope you can see my slide. I'm not sure, my PowerPoint. Good morning, ladies and gentlemen. I'm a little bit confused. I can't see the PowerPoint, so it's a little bit difficult now to present my topic, but I hope it will be
Your
sorted.
presentation. Can you please share your presentation? You cannot see your presentation.
Good morning. Good morning, Your Highness, Excellencies, ladies and gentlemen, and distinguished guests. I'm very honored to be today to be here and to talk about my topic, the future of cancer care. The sovereign sanctuary. Let's start with a thought. Next slide, please. Please, could you put up the next slide? We have built the most advanced hospitals in the world in history. But have we built a world that allows patients to heal? And I ask this question, and I'd like you all to reflect at the end of my speech and find the answer to my question. In the UAE, the family is center for cancer patient. And the last time I stayed in the UAE, I could talk to loads of people. And what I experienced was that the UAE is a country that's not only have a day-to-day running government. On the contrary, the UAE also works towards looking for solution for the future, reaching far into the future, and reflecting on possible risk, what could happen to come. My heart is, of course, deeply aligned with the Vision 2040. At the moment, please could you go back with the slides? It's not very good at the moment. Please could you back to the slide 4? Okay.
Yes, please continue.
Please could you put slide 4 up? We are treating 21st century cancer with 20th century environments. Why does this happen? We have, I listed a couple of issues there. You could see there was a processed food, the broad chemotherapy. Then we got gene technology and farming, and also we have there the problems with micro and nanoplastics. Because myself, I have 25 years of experience in cancer care, working in stationary hospice, in hospitals, in palliative care, in giving treatment, chemotherapy, and radiotherapy. I mean, everyone knows in hospitals we have all these infusion bags, the plastics we can see everywhere. We use it not only to give infusions, it's also whatever we do, plastic is all around us. And we know about the problem with the micro and nanoplastics. The same is also with the gene technology. Yeah, we have problems with the countries, the farming, but we try on dry earth soil to grow certain crops. But what does it do with our body? Another topic is the high sugary foods that we know about. But it's not like we did something wrong. Why did why did these problems appear? It's quite normal because our technology is gone so far nowadays, and our knowledge, we adapt it going with the new technology. And yes, we want to create, we want to do something good, but we also now at the point where we need to reflect, to go back and mop up these big gaps we got. Because if we don't do that, then it will fall back on us in future. We know that certain things appeared, and that's quite normal because we know at the time, we know the world has an overpopulation. We try to feed everyone, and we looked for shortcuts to create quickly some more food. But what does it do with the body? We got global political pressure at the time, but I do believe that stability in communication and seeing the world, our Mother Earth, where we stand on, and to talk with other countries to join the the solution, to join a future, will also stabilize that. Resources are running low. We need to find new ways. We will find new ways. There is no problem in that, but we need to focus. Patent trapping, silent research is a big topic today. I will talk about this. And media, of course, exposure. So the modern oncology faces three essential threats that traditional medical models fail to address. A, the environmental toxicity. The surge in microplastic, nanoplastic, and genetically modified food chains, which act as silent drivers for cellular degradation. These are silent drivers that compromise even the best medical treatments. Corporate gatekeeping, predatory patenting, and buy and bury tactics by major firms that stifle independent scientific breakthroughs. The support gap, a lack of holistic social and spiritual stability for patients, for their families during the treatment phase. We create shortcuts due to convenience and greed, where supermarket chains rule the health and well being industry, but not for the betterment for the populace. Production of enzymes and false products have impacted our natural biology, and because of these decades, we have allowed the greed of the food producers to cut corners and impact our health to such an extensive rate that we are on a tipping point of no return unless we look at more stringent methods to control what we eat and what the producers are allowed to use as substitute ingredients. I'm a procurist at VE Commodus, and we stand to our word and have pledged to the European Grow Code of Conduct for Responsible Food Business and Marketing. Our pledge stands to support localized crop cultivation and the exportation on a right trade by paying 50% back to the farmers to support development. That is very important point. But we need to reflect now, and with our knowledge today, must fix these shortfalls and create a healthier environment. Fast food, we know. We know about meat that will be chemically reclaimed. What does it do to us? Why do we need a gut health, microbiomes? We can not control the winds of global politics, but we can and must build a more resilient ship for patients. By merging the precision of medtech with the sustainability of nature and unwavering heart of charitable care, we create an environment where the future care is not variable but a constant. We need to fix these holes. So where do we get stuck? Large corporations often buy and bury or patent trap breakthrough research, stalling progress for profit. If I have, as a person, an idea that's a breakthrough idea, in my country, it's really difficult to develop this idea. It is difficult in this point that I can't talk to anyone. I can copyright it, but it's gone. I can send it to a patent office. That doesn't mean it's not gone. I can ask for help. We have loads of people, the brilliant researchers, doing research and looking to change the world, to better the world. We have also researchers like any other person who's there to work and to earn some money. As a business and having an idea, I need a researcher to fit. If I go to the government, at the minute, it will not help me unless it will say to me, I'm the owner of this patent. So, as a person having a breakthrough idea, it's often the patent will be buy and buried or it will be frozen. Here's a need to call for action. I would suggest a natural innovation zone that protects IP from hostile international takeovers. The solution would be, I call it a Swiss neutrality of cancer research. For example, in the heart of the UAE, where the cure belongs to the patient, not just the shareholder. Especially Dubai is a hub, I do believe, of stability and innovation, and a revolutionary operational structure that protects scientific IP from international corporation patent trapping, ensuring the UAE remains a permanent home of these breakthroughs, a center in Dubai, permanent home of the breakthroughs. And the center in Dubai where researchers, like you could see here, medical companies and patient exist on one level. Traditional structure often prioritize short-term dividends over long-term cures. By placing scientists and researchers on the same level as the management, we prevent patent trapping and ensure that the innovation remains in the hands of those who created it. This is about building a legacy, not just a company. In Europe, we speak of white bereavement when we talk about the journey before the cancer treatment. Loss of social ability, physical loss, mentally pressure, and spiritual. There we need to integrate the families more, the worries about the future, genetics. The second phase I call the green bereavement phase. Green standing for hope, the green sanctuary. Treatment, support, chemotherapy, radiation, stem cell harvesting, side effects, family, all these need to be looked at, not by single person, all of them together. We need to help these patients. We at the point now, a technical and an advanced point, there I do not need to tell the patient there's a first, second, and third line chemotherapy treatment. If the first doesn't work, I give them a second line treatment. We have stem cells, we have companies, they're so advanced that we can test the treatment, what's best for them. Also, we should be really stringent with us and reflect on chemotherapy. When it comes to, there is one chemotherapy I really like to talk about because it exists since 1975 and still be given on this planet. It has a 10% chance to do something with this cancer. It's been mixed over years in the countries and research, Switzerland and Australia, and mixed with any kind of other chemotherapy drug to try to save something or to do something with the patient, and it didn't help. So please let us take these treatments off the market and be true to the patient and say, I do not have any treatment for you. The green bereavement is the bereavement, where my workplace is, and where I can see we can advance, we can help families, we can help the chemotherapy patient. It's not only giving chemotherapy, it's how do you get the patient through treatment. The same as with radiotherapy. How do you get them through treatment? How they sustain the treatment. And the weak point, I so believe, it's every entity works on their own. The oncologist, that of course after research gives a good treatment, but is not really interested if the patient has a schizophrenic woman, wife at home, who he has to look after, the strain on the patient outside the hospital, the family, the children, they worry, they in school, they might need help, connecting services. Does the person has any support with the work he can't not go to, with payments, and the medical agencies too. My vision and VE Commodus Vision's Project V is a revolutionary support system providing physical, mental, and social fortification during the treatment struggle and after treatment, using sustainable agriculture to clean loop nutrition. Very important, using plants to counteract the effects of chemical treatments. This goal fits the Dubai 2040 goal of doubling green and recreational areas and food security. Our micro and nanoplastic water filter patent we have. Because it's so important, because we cannot clean the blood if we do not first clean the water. And our ORC X1 patent. By integrating the values of compassion and the sanctity of life, our proposed cancer sanctuary, like you could see on the pictures, will be more than a clinic. It will be a house of healing, where science respects the soul and the environment we have harmed is healed through our agri-tech innovation, providing a stable plastic-free world for generations to follow. And as you could see, my 4 core pillars, how can we do it? Decoupling research from political volatility. Scientific progress should not be fair-weathered. The necessity consists of decentralized private-public partnerships that ensures R&D funding remains consistent even when international relations or trade rules are strained. How can we achieve it? Of course, with self-sustaining innovation and localizing medtech production. Integrating botanical green resilience, linking research in sustainable agriculture to cancer care. In times of global supply chain disruption, looking forward, homeopathic comprehensive approaches and botanical research that offers a more resilient, earth-centered pharmacy that is less dependent on fragile global logistics. How can we achieve this? For example, VE Commodus Project V plays a part of a leading to shift from pure synthetic to integrate sustainable treatment models. The human anchor, it's a very important point, and pillar charity as a bedrock. When political pressure mounts, social safety nets often fray. My experience with the Hospice Initiative in Rostock and the Tenevis Cancer Care Charity in Wales are charitable organizations, also compromising and supporting research. And they're not just extra. They are essential, stable environment that catches patients when system faults. How can we achieve this? Of course, by advocating for compassion-first infrastructure in a hospital management. And the 4th pillar, healthcare sanctuary, proposing that cancer care be viewed as a neutral zone in global politics. Much like the Red Cross, cancer research, patient support must be treated as a universal human right that transcends borders and political disagreements. How can we achieve this? Calling for international stability pacts specifically for oncology data sharing and drug access. The alignment Dubai. The Green Sanctuary is designed to be the cornerstone for the Dubai 2040 Urban Master Plan, transforming the city into a global epic center for ethical med tech. We propose a facility that bridges the gap between high-level oncology and environmental restoration. By anchoring this initiative, the Green Sanctuary in Dubai, the UAE secures biosecurity, independence from global pharmaceutical supply chains, legacy, the house of healing that honors Islamic values of Rama mercy and Amana sacred trust. Innovation leadership, the first global hub to successfully merge agri-tech, clean food nutrition with oncology. Let us build a sanctuary where the cure is never silent by a patent and where the environment we have harmed is healed by the science we create. Seeing patients going through chemotherapy, going through white bereavement, you have the diagnosis, you've been hit by a bus, your life has been destroyed. With one word, you have cancer. We need to treat it. You have a family. You don't know what's happened next. You're happy to go through treatment. Who's looking after your body? Who's helping you with the side effects? Who's helping you on the day where you feel really low? And we all know that chemotherapy, but we have really, really good success stories, but it also have a drain on the body. That our bone marrow, everything works very hard, and we need to support in the green bereavement these patients to get really good through chemotherapy and how to support them, not to fall in depression, not to lose more weight, to try to have the best outcome in the end. To protect the vision for the UAE and for humanity, I'm seeking visionary partners to enter the circle of trust. Through a formal NCNDA, together we will ensure that the protocols remain legacy for the 2040 generation. Thank you very much for listening today. I'm a little bit sorry that the slides were out of sync, but I hope you had still a good time.
Thank you, Mrs. Vitali, for your insightful presentation and valuable contribution to cancer care. It is my pleasure to introduce Dr. Leon Rayford, oncologist communication health professional, who joined us from Australia. He will be presenting exploring the benefits of cancer patient online peer support and the risk of misinformation that could lead to treatment discordance or non-adherence, a mixed method scoping review. Kindly join me in welcoming him.
Can everybody hear me?
Yes, we can hear
Okay,
you.
great. Well, it's good afternoon to Your Excellency, fellow presenters, and thank you very much to the conference organisers for this invitation to introduce our area of research. I hope you don't mind, but I'll be continually flicking back to my laptop with all the information on. Yeah, I would also like to thank the virtual audience that's out there that we can't see, for those around the world for coming to listen, and a special acknowledgement to the bravery of people living in the UAE and neighbouring states who've had a rough time over the last few weeks. Well, I'm Leon Rayford, as the conference organiser has just mentioned. I'm Leon Rayford. I'm not a medical doctor. I'm a PhD holder. And I have an interest in treatment non-adherence, specifically in cancer. And that has been the theme of my PhD thesis, which was finished last year. And now I'm going to introduce an article we had published at the beginning of this year.
Can you
Just
please share your screen?
Can you hear me?
Can you please share your screen? We can hear you. Can you please share
Yeah,
your
sure.
screen?
I'm going to share the screen right now. Oops. Excuse me 1 minute. Oops. Let's get to this. Entire screen. Right. Into this. Can you see the screen? Hello?
No, we cannot.
Okay. Sorry about this. Can you see the screen?
No.
No, we cannot. If you're unable to share the
Wait a minute,
screen,
we'll just try this
Steven will share the
now.
screen.
Oh dear. Would you be able to put my screen up? My PowerPoint?
Yes, we will do that. Yes.
Oh, that's fantastic. Thanks very much. So I'll just move on now to this topic. So you would have noticed a different topic in the program. This has been changed at the last minute to give a bit of a roundup of past research, where we are and where this is, where this stands in what we're doing. So this is a non-clinical study that has at its core treatment non-adherence in cancer patients. So our focus is on treatment non-adherence, as just mentioned. And what I'm going to be doing is providing some background on the topic in the next slide, on which is concordance in EHRs, not what is shown in the program. So concordance in electronic health records, particularly the narratives. Well, in fact, the narratives, not the coded information that's on EHRs, but the narratives that oncologists note down when they've seen their patients or after they've seen their patients. So it's particularly about communication and information that happens between the patient and what's recorded in the EHR. So we'll just move to the next slide. The next slide, please. Yep. Okay, so just to give you a roundup, I'm sure the oncologists here are aware that treatment non-adherence is quite high. In fact, around about 50% in some cases, much higher, in some cases much lower. I've used the figure 50% just to give a roundup of the seriousness of it all. So how we've come up with this figure is that traditionally, or not myself personally, but past researchers, traditionally treatment non-adherence is measured using patient surveys. They tend to be quantitative, things like satisfaction surveys, quality of life surveys, and various other surveys. And a figure is derived from those surveys as to who might be compliant. Overall, I'm talking about researchers now, from a research perspective, who is compliant or who is adherent to their treatment. Now, the quality, where our thesis began is on quantitative surveys that have arrived at this information about treatment non-adherence in cancer. The quantitative surveys have given us the figures, and these are consistent over 10, 20 years of a high rate of non-adherence. They tend to focus on compliance and medication, not treatment generally. But the research, the past research has been almost entirely, I would say probably 95% quantitative up until about 2015, and mostly numeric. So, and then another little aspect that's come into all this since our interviews with oncologists during the thesis is that oncologists measure non-adherence, or don't measure non-adherence, assess non-adherence in a different way to the researchers. So they may be looking more at breaks in between medication treatment, which is not assessed in the research scores. They're not looking at those periods where it might be that that patient doesn't need to be on that type of medication for that long. So it's been measured quantitatively, and what we've looked at now is all of the qualitative notes in these quantitative surveys. When I say all of them, a portion of them, a small portion of them. And from that, we've arrived at an assessment of, or an overview of where we are with treatment non-adherence. And basically, it has remained much the same, and it has not been explored and explained fully. Very little has been done to explain the phenomenon in cancer. Those studies that have been very, very good, but there's very few of them. So for the first time now, we can use natural language processing of anonymous patient commentaries to derive far more information about the cancer patient experience. I'm talking about online information that is found in peer support groups. We can use sentiment analysis, a technique called sentiment analysis, to find out what the patient is actually thinking, what they're experiencing, or maybe not what they're thinking, but certainly what they're experiencing in real time, and what they think of their treatment and all those other issues that go alongside treatment, which is not necessarily recorded in the quantitative surveys that have been dominating research for so long. So what we intended to do was use text mining, sentiment analysis, our own algorithms, and online surveys to see where we are with the patient experience. This is but we found that it was very complex to derive another algorithm for this purpose. And there were many studies out there that could do the same thing, that had done the same thing, but their focus had not been on non-adherence. But there was plenty of information in there to extract and apply that to non-adherence, which we did. And that was with our first scoping review, which has been published in January, which gives us insight into all these previous studies of the cancer patient experience as far as sentiment analysis is concerned, and other NLP techniques, which is short for natural language processing. So I'll move off from there to the next screen. So we can see why it's very important. As just described, it's almost around 50%, and sometimes much higher. As mentioned, there is a long way to go with qualitative validation interviews with oncologists, who tend to have a different perspective, and they have not been interviewed thoroughly on this topic. So research, there's been loads and loads of it, but the oncologist has been less consulted in terms of what is non-adherence, in my view anyway, from the research we've done, and what constitutes non-adherence, and what isn't. During this process of trying to establish what was going on with treatment non-adherence, excuse me, I'm just going to my other screen now. Excuse me. Yeah, so in the time that we've been trying to study non-adherence, both through sentiment analysis of patient commentaries in online support groups particularly, and through text mining of electronic health records. What we found was that it's very difficult to define treatment non-adherence, almost impossible, unless you look at it qualitatively. So that has been the main focus of my research, has been qualitative research using meta-ethnography, I can't even say the word, meta-ethnography techniques, and scoping reviews, several scoping reviews, and patient interviews, and a number of other techniques to find out what these findings all mean. So it's quite a complex area for the qualitative researcher to unravel. So what we found, or what I found during the research, was that the best way to look at it was treatment concordance. What is treatment concordance? Well, it doesn't appear so often in the research. The term is not articulated very often, but it basically means an agreement between the patient and the doctor on the type of treatment that they're going to go through, and any questions and queries that the patient has had being satisfied. And there's a mutual understanding that this is the best way of going about it, and not just being told, hey, as it says there, medication compliance, the doctor knows best. So we've moved on from that, or we would like to have thought we've moved on from that, but in fact, my studies have shown that we're still in a transitional phase from medication compliance to treatment adherence. Now, treatment adherence, that term was coined by the World Health Organization back in 2003, a long time ago, and they defined it as in a much more holistic way. And this is where we're moving to. So from compliance, the doctor, who obviously knows best, but the patient needs to share that information about themselves, which the doctor might not know. So in the past, it has always been a case of the doctor really provides the instructions and the patient responds. That perhaps until about 2015 or something. So for the last 10, from what I can see, these are just rough dates. From the last 10 or 12 years, we've been moving heavily into adherence, but medication compliance still features very much in some of the research, and in discussions with oncologists, they still talk compliance. So now we move on to the next slide. That gives you a bit of a rundown on compliance and adherence. So to understand from the information that we're looking at, the analysis of the information through a narrative synthesis, basically, and a thing called a discourse, or a concept called a discourse analysis, which is where I look at all the information we've got there and look for inferences, whether it be sentiment analysis or whether it be text mining of the electronic health records. I'm looking for inferences of treatment non-adherence, what we've identified as factors that influence this behavior. So we're looking at both the patient and the way the patients discuss their treatment with others, with their peers particularly, and the way the doctor records or doesn't record adherence or non-adherence in the electronic health record. So the easiest way I've found to identify that is treatment concordance. It's more easily identified that the patient is going along with the treatment. They've had some input. You can see that from the commentaries, and what they've said to the oncologist is in fact in some way showing up in the electronic health record. Unfortunately, most often it isn't. And this is where we have that problem of... So basically, from our prior studies, I'll just quickly mention this. From the first initial scoping review, 4 main themes had emerged. And what we found that the patient, in their discussions with the oncologist, was not only looking for information following discussions with their oncologist, they were also looking for emotional support. And we found that emotional support may be on par with information. It could be just as important. So that's the reason why they're now spending so much time online. So this whole program of research concerns what the patient is doing online, how the oncologist is communicating with the patient, and what's being recorded in the electronic health record. So what we've really found is that perhaps 70%, rough figure, very, very rough, of what's being considered by the patient is not being discussed with the oncologist. So they've got many queries, they're going away and they're looking online, they're not going back to the oncologist, or they might go back to the oncologist, but they've got more information. So we're in a time now where a lot of information can be extracted that previously couldn't. You'd have to go through a whole encyclopedia of books, and nobody would do that, say 20 years ago. So next slide, please. Oh, sorry, before you do that, could you go back to that? Yeah, next slide. Next slide is great. So we've got unmet emotional needs. We've got suboptimal information and communication. So what we mean there is that the oncologist, as far as the patient was concerned, I'm not blaming the oncologist, of course, and I'm not a doctor. This is purely from what we're reading and seeing both online and or not seeing in electronic health records. So there is suboptimal information and communication. So there's not great communication. There is in some cases between the oncologist and the patient. There's a bit of a gap there. And we're seeing that because of the amount of time that the patient is spending online trying to get clarification, trying to get endorsement of what they're doing, that the treatment was best for them, and all of that. And that's not really being discussed with the oncologist. Having said all that, the oncologist doesn't have the time to listen to all of the concerns of the patient in a short consultation. It would go on for quite some time. So we're also looking at how we can capture that information in an area, or how we can somehow oversee it or provide some oversight so that the patient is not ending up with a whole pile of misinformation, a lot of it very good information, but some misinformation, attending a consultation and in a very anxious state, having made comparisons with someone else's disease that doesn't fit their disease, doesn't fit their condition or their stage in cancer or whatever, but the information is basically wrong. So we have found that there is this scenario where there is a lot of extra stress caused by patients going online looking for information. So these are the gaps on that research. Misinformation. Patients would even recognize clinician bias. They felt there was some bias towards one particular treatment and not another, and they weren't being shown the whole, all the options. If we could move on to the next slide, please. So these are the unmet patient information and communication needs that we've identified. Emotional needs that don't appear in the electronic health record, which the patient is expressing in peer support, distress, fear, sadness, surprise, spiritual pain, the lack of information, resulting in more activities. And a new area of research for us is possibly somatic symptoms or somatization, where things are made much worse through what they've seen and read online, and not necessarily something that they actually need treatment for, perhaps, but the oncologist can tell me much more about that. So far, we have only interviewed a handful of oncologists, and perhaps 6 or 7, as well as a few dozen cancer patients in qualitative interviews, as long as our other research, which is the main bulk of it, which is going through all the previous quantitative surveys and the final results and conclusions that other researchers have come up with. But the thing that stands out with me the most in all of this that keeps coming up is patient concordance. it's an integral to PCC, patient-centered care or person-centered care, which is of great interest to, well, not of great interest, but it's a concept that is being closely followed by nursing staff, we hope, and doctors. But it's not showing up in electronic health records, and it's not reflecting itself in the information that we see online, which gives much more depth than just quantitative surveys and scores. If we go on to the next one, please. So our first published review, I'm reading straight from this now, provides key findings from diverse NLP studies, sentiment analysis primarily. This study primarily uses sentiment analysis of online information and peer support groups. So this has been directly where patients go online and they join a peer support group. They're anonymous, which is great. No one needs to know who they are. So it really does fill a gap. It's just, what they do in there and the information they walk away with, that's the problem. And in the study, we've demonstrated how traditional patient satisfaction and quality of life surveys do not present the patient experience fully. Although they do a great job, but they just don't present all aspects of patient concerns and priorities. So today, in the following slide, the one after this, we provide an overview of unstructured information, oncologist notes used in text mining and other NLP techniques used to mine information from electronic health records. What we've had to do, because no one really has spent much time on treatment non-adherence, cancer patient treatment non-adherence in specific, I've had to use discourse analysis as an approach to finding inferences of treatment concordance or discordance. So in other words, I'm looking in the results, as I did with sentiment analysis. In the end, we didn't realize in the beginning that we'd find very few studies, if any, that focus on treatment non-adherence. So now looking at electronic health records and inferences within there. So for example, if in our interviews with patients, they've said, yes, the oncologist asks me about my medication and I tell him, yes, I'm doing it, or I've got a problem. And the oncologist will say, well, we'll do this, that, and the other. But it's not reflected in the electronic health record in the notes that we see. And one of the reasons is that we're in the infancy of text mining of oncologist notes for that very purpose. But having said that, it does stand out rather a lot in almost all the interviews that none of the patients were aware of the oncologist making notes. So in other words, it has to be transferred after the consultation, whatever the important findings were during the meeting. But we feel that there also maybe. I'm rounding this up a bit because there's a lot of information coming out of this research, but we're also finding that oncologists are not that keen on recording negativity from patient consultations in electronic health records. So it may not be showing up for that reason. The next slide, please. So why is our current review a work in progress? So this is a work in progress in brackets. Why is our current review different? We've already had the scoping review using sentiment, or the results from sentiment analysis of the cancer patient experience. We're now, if you like, triangulating that with the electronic health record and interviews with oncologists and qualitative surveys that have already been conducted of reports of oncologists and barriers to the barriers to the use of electronic health records. So what we found is that mostly the prior studies catalogue extraction methods or clinical concepts. Our current review, a work in progress, focuses on how documentation design, language used, and workflow features identified through NLP text mining and qualitative surveys with oncologists. I found these to actually be as important as the text mining studies that we've been looking at. And unfortunately, there are very, very few. In fact, I don't think there are any that I've managed to find that focus on treatment non-adherence in cancer patients as a topic of text mining. So the next one, please. Next slide, please. So basically, in this current study, the one that we're looking at with oncologists and specifically text mining and some surveys and interviews, we found that the main barrier to information for reporting information in an electronic health record, this is what the prior research tells us, is that most of the templates, the electronic health record templates, are compliance orientated. In other words, they're more orientated towards medication compliance, not treatment adherence as a holistic concept. Okay, I'm almost running out now. So we've got late documentation being prescribed by the oncologist. Okay, I'll round up. We're putting it all together. The patient voice, that was the first scoping review we did, why patients may be non-adherent. So that's been published. You can find that online. It was published in January. What the electronic health record tells us about oncologist communication is what we're doing now, text mining, and the oncologist's view of electronic health records, what the barriers are, and there are many barriers. And we're finding this out through qualitative reports and surveys. You can't find it out through text mining. It will only give you an indication, for example, why aren't there adverse effects reported? Why is there no information about social determinants of treatment adherence? Then we've got this other thing that we're going into now, which is a whole other area, which is misinformation that ends up with patients possibly displaying somatic symptoms in some scenarios. We're not sure the extent of that, but that's where we're going now. And finally, the last page, please. So that will be the next area of research. So one of the main thing that we found from the interviews with our oncologists, just this small group, is that patients often suffer unnecessarily from an increase in anxiety due to comparing their treatment and condition with others when the comparison cannot be drawn, different stage of cancer, etc. That's the problem with online misinformation, the biggest problem. The views and experiences of oncologists and others today on this topic is most appreciated. Thanking you all very much for your time and listening to this presentation.
Thank you, Dr. Leon, for a valuable insight. I do have a few questions if you would be so kind to answer them.
Sure.
How does socioeconomic status influence the adherence to cancer treatment?
Sorry, I can't hear that.
How does socioeconomic status influence the adherence to cancer treatment?
It's an area we have not included in our research, not at all. The financial determinants of, you're talking about economic scenarios?
Yes, yes,
Yeah,
socioeconomic.
we haven't studied that yet. Social determinants, yes, but not economic considerations. It's one of the factors of treatment adherence defined by the World Health Organization. Economic factors, there are 5 factors, but economic factors is not one of them, that we're going down that road. And the reason for that is there's huge differences between in economies between, say, the UAE and Vietnam, just call a few out, or Australia, and one of the islands, Solomon Islands or something. So we can't add that in at this point. So it is a limitation.
And one more question. Can digital health tools like apps and reminders significantly improve the adherence rate?
No, they didn't. We did some studies. We checked out previous research. There was a huge number of researchers has taken place on a very large scale over a long period of time, and reminders did not work. They just didn't work. They didn't make any change. They might work with some people, but overall, they didn't make any notable difference. So I'm not going down that road of apps. It's more a case of not at this point in the research anyway, it might come up later, but it's more a case of what the patient understands. It's the misunderstandings that seem to be a big problem out there. And a lot of it has to do with the access to a tremendous amount of information. But the other problem is the electronic health record is designed for medication compliance and the interests of the pharmaceutical industry, perhaps. I'm a little bit biased there, and not treatment adherence as a whole. So it doesn't even have the places to put that information in. And if it's scrambled into the notes, it might just not be detected in text mining.
Thank you very much. Next, we have Dr. Associate Professor, Department of Pathology of Azerbaijan Medical University from Azerbaijan. She will present on thyroid gland injury and compensatory adaptive mechanisms under the combined effects of hypoxia and infection. Kindly join me in welcoming her. Can you all hear me?
Not yet.
Is okay?
Okay, it's visible. It's okay.
Good morning.
Yes, please continue.
Is good or not?
Good,
Yes,
it's
I can hear
visible.
you. Please continue.
Bir tane F5'i basın ki bütün ekranı tutsun.
Is good or not? F5'dədir də, F5 eləmişəm.
F5 eləmişsiniz? Ha, onda görünür. Buyurun, başlayın.
Yes, we can hear
Share
you. Please
eləmişəm də
continue.
mən.
Share olunur.
Distinguish. Ha?
Ekran görünür.
Gəlir səsim.
Gəlir.
Görünmür prezentasiya.
Görünür. Başlanğıçda görünür.
Hagim xanım,
It's visible. The first
prezentasiya
page,
görünür.
it's visible, yes. Görünür.
Prezentasiya hər şey görünür.
Görünür.
Başlayayım.
Buyurun.
Okay. Good morning, distinguished colleagues and esteemed members of Scientific Council. Thank you for inviting me to this excellent, wonderful conference event. I would like to let you, I have today unstable internet, so that's why I apologize before in advance. So it's not depending me. It's an honor to present our latest research finding today. You know, endocrine system plays key role in our body function. Uh, we have studied the endocrine system. It's like morphofunctional condition of endocrine system under the impact of different pathological conditions, including hypoxia, then infection such as peritonitis. Um, it's like one of part of hypothalamo pituitary thyroid axis, and it's like suprarenal axis. We have studied different part of that axis, that ring of that axis. So that's why we have investigated different portion, pathological condition, pathological situation of endocrine system. But today I would like to share today with you. It's like morphological and functional dynamics of tissue response under the hypoxia and the infection condition. Specifically, we have analyzed how the two factors, hypoxia and infection, I mean peritonitis, interact to drive morphological progression over time. It's very interesting results we get. As we know, hypoxia and infection are frequent companions in many clinical scenarios, from chronic wounds to organ failure. There are isolatedly the impact different ring of uh, a different ring of endocrine system. So that's why I'm going to give information just about thyroid gland pathology during hypoxic condition and infection. I mean, combined effect of hypoxia and infection. Our research was conducted at the Scientific Research Center of Azerbaijan Medical University. I would also like to mention that I am Deputy Director of Scientific Research Center of Azerbaijan Medical University. We utilize the longitudinal model, observing change in specific intervals to 5, 15, 30 days. We focused our analysis on two distinct areas. It's like, morphologically, a thyroid gland has, topographically, thyroid gland has two portions, peripheral and central portion. I mean, peripheral and central zone. So that's why we will describe today which portion of thyroid glands more vulnerable to hypoxia and infection. If we look at our first set of data, we see the individual impacts of hypoxia and infection, especially Staphylococcus aureus. It's like peritonitis. We have administrated, it's like solution of Streptococcus aureus intraperitoneally. Then we have investigated what pathomorphological change will occur. Under hypoxia alone, we observed it steadily increasing morphological markers in both zones, I mean in peripheric and central zone of thyroid gland, peaking around the 15 and stabilizing period 30. It's like chronic hypoxia and chronic infection. Under the infection alone, the progression followed a different trajectory, where the peripheral zone often shows earlier sign of inflammation. It's different. In hypoxia, we saw a central zone of thyroid gland, but under the infection, that pathological, it's like events, I mean, pathological process more often damage earlier stage of peripheral zone, okay? Then response compared to central zone, it's like a very vulnerable zone of the thyroid gland. However, in both individual cases, the tissue compensatory mechanism managed to keep the severity within the manageable range. The what does happen in synergies effect of and peritonitis, I mean infection. The most significant finding in our study appears with the combined the stressor factors. I mean hypoxia and infection. In the hypoxia and infection group, I mean in combined group, both effect, you observe that we call it synergies pathological effect, one helping to other. It's like infection creating, it's like inflammation, and inflammation is creating hypoxia. They are synergies in both. They are helping one to other. By day 15 and day 30, the percentage of severe tissue damage indicated by, you will see here, as you know, this one is course of experiment, okay? Then we have investigated by histological, electron microscopic, immunohistochemical, and ELISA method and morphometry. The control, we have divided the animals into different group. In first group, control group, also five in each one is four, and each one is 5 animals. Fourth group is known as combined effect group. I mean, hypoxia plus peritonitis infection. It's known as also in our case main group. We have included there 20 animals, and also we have investigated that pathological process occurring in thyroid gland in 15 and 13 days of impact. And also we have, as you saw in a picture, visible here, and below the low row you are looking electron microscopic picture. You know, here it's like swelling of mitochondrial leakage. It's like damage of endoplasmatic reticulum. There are different electron microscopic events occurs. And also we have investigated that pathological process. This one is a diagram showing it's like pathological process occurring in thyroid gland. As you know, as you see there, bluish color. This one is central zone, and another one is peripheral zone. As you're looking at this diagram, the central zone peripheral zone more vulnerable for hypoxia and also infection. And other one is we told just histochemical method of investigation. Okay, you are looking increasing of marker CD4 and CD8 in both region, both zone of thyroid gland. As you are looking here, 3 plus increased extraperitoneal exponentially. It's like showing it's like increasing of severity of pathological condition. While hypoxia or infection alone showed moderate change, their combination led to breakdown of cellular homeostasis. It damaged homeostasis. As you can see in diagram, moderate and severe categories dominating tissue profile by end of experiment. I mean, in first month of experiment. What can I say in conclusion? In conclusion, our data demonstrate that hypoxia significantly exacerbate the inflammatory damage caused by infection. The synergy suggests that in clinical practice, treating the infection alone without addressing tissue hypoxia or tissue oxygenation may lead to suboptimal outcomes, results. So that's why it's oxygen. It's very important. It's like element, substance of metabolic process. So that's why any hypoxia condition is leading to different types of degeneration, including in thyroid gland also. This finding will serve as foundation our next year strategic research goals. I hope that next we will investigate different endocrine axes by combined effect of hypoxia and infection. Thank you for your attention. I'm now open to any question. Thank you very much.
Thank you, Dr. Sunira, for your informative and practical presentation. I do have a question. What compensatory mechanisms does thyroid gland activate under combined hypoxia and infection?
Hypoxia and infection, there are different rings of, it's like pathological, morphological, it's like degeneration and damage of thyroid gland. But hypoxia isolately, I mean, alone, it's damage. But it's finally leading to inflammation. It's activating the fibrocyte activity, and also I'm talking about chronic hypoxia. It's not acute hypoxia, but any chronic hypoxia is leading to activating of fibroblast connective tissue elements, or replacement of parenchyma of thyroid gland to with connective tissue, fibrous connective tissue. But inflammation here, it's like joining effect, it's a deepening of pathological process. It's increasing the severity of pathological process. So we want to show, I would like to show, for example, any pathological process, any infection process, it's not, we have to pay attention. It's like complex. Without, for example, it's like manage of hypoxia without eliminating of hypoxic condition. We can't treat infection process. So they are synergy. So that's why treating one, we are helping to other one. So we are facilitating of infection process. In some cases, maybe that any pathological process, any pathological condition, hypoxic condition, okay, maybe a pathological process, infection or peritonitis, and other one inflammatory process lasts the course of that pathological course lasts for some days, for some months, weeks. So that's why we are treating, we are removing, we are eliminating that hypoxic condition. We are helping our body to build, to recover cellular homeostasis, to helping to treat that pathological condition.
Thank you, sir. I would like to open it to the audience. Is there anyone else who would like to ask a question?
Sorry, I can.
I'm asking if anyone else would like to ask a question.
Anatomy? I don't
You
hear.
please little loudly talk because not hearing.
Okay, thank you, sir. Next, we have Dr. Matus Koma, leading scientist
Yes,
at
thank
the
you so
Department of
much.
Pharmacology, Medical Faculty from Slovakia. He will present on tigecycline enhances the cytotoxic efficacy of FOLFIRINOX and GEMPAC in pancreatic ductal adenocarcinoma cell models. Kindly join me in welcoming him. Okay, we will be having a short coffee break of 15 minutes. Kindly join back in 15 minutes. Thank you very much.
Break time. Now break time.
Welcome back, everyone. We hope you had a refreshing coffee break. Our next speaker is Doc. Our next speaker is Dr. Aliar Bayova Aygun Aliar, Assistant Professor of Department of Cytology, Embryology, and Histology of Azerbaijan Medical University, joining us from Azerbaijan. She will speak on ultrastructural study of changes in the pulmonary vascular compartment under macrophage migration inhibitory factors. Kindly join me in welcoming her.
Hello, everyone, dear chairman and attenders of the conference. I appreciate you for the participation in this conference, and I am greeting you from Azerbaijan Medical University, from sunny, shiny city of Baku. With your permission, I would like to present my presentation on topic ultrastructural study of change of pulmonary vascular compartment under macrophage migration inhibitor factor. First, I want to show you that 1 minute. Just a minute. First, I want to show you about circulation, blood vascular system of lungs. Lung has pulmonary and bronchial circulation. The pulmonary arteries, as shown from the slide, supply the oxygenated blood to the lung from the right side of the heart at a rate of 5 liters per minute. Branches of these vessels follow the bronchial tubes into lobes of the lung. When they reach to respiratory bronchioles, these vessels form extensive meshwork of the capillary network. That capillary network composed of continuous capillaries. The blood in the capillary bed become oxygenated, then drain into the veins of increasing diameter. These tributaries of the pulmonary vein carry oxygenated blood and travel into the septa between lobes of the lung. Bronchial arteries that each branch of the thoracic aorta bring nutrient-laden and oxygen-laden blood to the bronchial tree, interlobular septa, and pleura of the lungs. Many of the small branches anastomose with the pulmonary system. Others are drained by tributaries of the bronchial vein, which return to the blood to the azygos system of the vein. On the slide, we see that what I talk about branches of vascular supply, which that to pulmonary and bronchial circulation. Next, I want to talk about macrophage migration inhibitor factor. Macrophage migration inhibitor factor, that is key inflammatory cytokine, pro-inflammatory cytokine also, which has been implicated in aggressive acute inflammation. The MIF protein has a molecular mass of 12.5 kilodalton and consists of 114 amino acids. MIF can have dual function. It acts as protective in host immune responses, but in some cases, it's exacerbating host injury. In scenarios where MIF play a protective role, may enhance the activation of immune cells, particularly macrophage, and facilitated the release of pro-inflammatory cytokines, contributing to the efficient clearance of invading pathogens. Conversely, the deleterious effect of MIF in other infections may be due to its potential to intensity inflammation and contribute to tissue damage. Richly vascularized respiratory organ lungs affected to some inflammatory mediators that it lead to pulmonary disease. But in chronic inflammation and autoimmune disease, MIF is thought to play a role in maintaining inflammation, leading to persistent tissue damage and dysfunction. In the context of respiratory disease, it has been implicated in the pathogenesis of asthma, cystic fibrosis, respiratory distress syndrome, and acute inflammation. Next, in our that research, we have to aim of our research is ultrastructural examination, the deviation of the lung vessels after single dose of intravascular administration of macrophage migration inhibitor factor, which is gained from the company of Prospect Protein Specialists by code number 193 from Nason of Israel. The object of research were lung tissue that is purchased from 60 adult male Vistar albino rats, which are taken from Scientific Research Center of Azerbaijan Medical University. The animals were grown and kept in pathogen-free condition of the vivarium of the same center, including the temperature, humidity, as well as the regular light dark cycle with free access to food and water. And all laboratory work, it means experiment, was conducted under the European Union Directive 2010/63/EU on the protection of animal used in scientific research and other applicable ethical standards and guidelines when handling laboratory animals. The experimental animals divided into three groups: intact group, which is number 12, and the comparison group or placebo. So it's administered intravascularly, 0.3 milliliter of physiological solution, and the main group, that is in number 36 rats, it's administered macrophage migration inhibitor factor in amount 1.39 microgram, which dissolved in physiological solution, but total volume was 0.3 milliliter. The lung tissue intravascular administration of single dose of macrophage migration inhibitor factor induced inflammatory response. During the experimental period, no rats died in any group. Rat excluded from the experiment under ketamine anesthesia after administration of MIF and saline solution. Here shown the protocol for this experiment. And in two groups, which is named comparison and main group, we subdivided animal into 6 subgroups, depend on the time when they are extruded from the experiment. They extruded out from the experiment on 2 hour, 2 day, 3 day, 7 day, 15, 30 day after injection single dose of the macrophage migration inhibitor factor. The lung tissue obtained from the animals for histological analysis, fixed in the formalin embedded in the paraffin that is sectioned in 3-5 micrometer thickness, and for morphological evaluation was conducted with the assistance of the hematoxylin eosin staining. On electron microscopic investigation, the tissue specimen is fixed in the mixed solution, which is contained 2.5% buffered glutaraldehyde, 2% paraformaldehyde, 4% glucose, and 0.1% picric acid. The fixed tissue handled in the araldite upon blocks. To conduct ultrastructural examination, semi-thin section in 0.51 micrometer thickness from araldite upon blocks, processing, and staining using duplicate staining method by methylene blue, azure 2, and basic fusin. The chosen region for the examination is stained to ultra-thin section in thickness 50-60 nanometer, and they are stained with 2% uranyl acetate solution and 0.6% poor lead citrate. Then on the transmission electron microscope, GEM 1400 Joule Japan at 80 kilowatt investigated all ultra-thin section and gained electronogram. First of all, I want to tell intravascular administration of the macrophage migration inhibitor factor into the vessel system first affected two endothelial cells, which the endothelial cells lined in all blood vessels. And lung is abundant with the network of vessels. After administration of this MIF, pro-inflammatory cytokine MIF detected morphological change in the vessels. And vessels in the lung is subdivided into two types. Bronchial vessels, it is large, medium-sized, small-sized vessels, and capillary with specific function. Capillary with specific function, it's named microvessels, and precapillary arterioles, postcapillary venous also included there. Microvessels also is lined by endothelial cells. Capillary essential for gas exchange, and it's particularly vulnerable to injury. All vessels lining endothelial cells, that is account for half cells of the lung. Endothelial cells pivotal in maintaining vascular integrity and lung function, regulating processes such as blood vessel tone, blood fluidity, and the barrier function against pathogen and fluid leakage. Endothelial cells also contribute to the management of the body's inflammatory responses, playing a crucial role in maintaining pulmonary hemostasis. As a result, the first we show to you demonstrated from normal intact lung tissue taken the specimen, vascular endothelial cells that create tight barrier to fluid to protein passage between the interstitial and vascular area. That's why alveolar the space is dry without any exudate, without any fluid, because that vascular endothelial cells create tight barrier for this part. And that's why dry alveoli visible on histological and in the middle ultrastructural examination, and only in the alveolar lumen are visible macrophage dust cells. But endothelial cells, when exposed to the macrophage migration inhibitor factor, that compromise the integrity of the endothelial barrier. This barrier disruption increases vascular permeability, which will result in plasmorrhagia into the interstitial area, that is created pulmonary edema, and to the airspace, which is a flooding of the alveoli. The first target, it's visible already after 2 hours of the MIF administration, and that time MIF disrupted barrier vascular integrity initiated pathogen-associated molecular factor-mediated inflammatory signaling and tissue injury. Cytokines promote lung endothelial permeability and leakage of the plasma. Due to increased permeability of alveolar capillary membrane caused to microvascular leak that resulted in flooding of the alveolar air spaces with inflammatory exudate. That slide taken after 2 hours of the MIF administration, and there are visible exudate in the alveoles. That is a signal of the inflammation, alteration of the lung tissue. And that is taken from intact. When we compare, we can see deviation which are happening during 2 hours after MIF administration. On electronogram, we can see ultracellular morphology, how it's changed, especially in the capillary endothelial cells, with that visible degenerated endothelial cells in the blue arrow is marked. Lumen of the capillary is attracted attention because it's closed by the plaque of erythrocyte, thrombocyte. In addition, by a red arrow shown that plasmorrhagia, which is a plasma exit leave blood capillary and enter to the interstitial tissue, interalveolar space, and they also have some bundle of collagen fibers. In the large vessels, which is accompanied the branchial network, we can see endothelial cells, which is swollen, destroyed, and a large amount of the polyribosome on the cytoplasm. And in the periadvential area, it's surrounded by edematous fluid. Next slide shows to us interstitial branchial network supplying vessels, arterial vessels especially, that endothelial cells is swollen and visible there are some microcytopody, vasoconstriction, and surrounded it by periadventitial edematous band, which is shown by blue arrow. And also the same we can see on the light microscopic area, which is a surrounded periadventitial edematous band. On the large vessels also, edematous fluid is visible, which surrounded adventitial layer, that the large arterial vessels, internal elastic membrane there are visible. And the endothelial cells also bulged its to the lumen, its nucleus is enlarged. In the next slide, we see capillary, the small vessels, which is a performing specific function. They are part of the aerohematic barrier. Dilatation of the capillary, stagnation of the capillary after 2 days of the MIF administration is visible, and multiple change in the morphology of endothelial cells observed from early period of lung inflammation. On next slide, we can see histological and 3 electronograms, which they are showing to us. Vessels is occupied by red blood cells. It closed. There are visible plaques of erythrocyte. And in the histological slide also, it's very sharply detected because capillary obstructed by plaque of erythrocyte on second, third days of the experiment. Next slide is showing to us endothelial cells on its cytoplasm in scale bar 200 nanometer, visible a lot of number pinocytic vesicles. And in addition, nucleus enlarged, which is a bulged into the lumen of the vessels, periadventitial edematous fluid accumulated. Here also nucleus of endothelial cells bulged to the lumen and polyribosome are visible on the cytoplasm. Pericyte, that is postcapillary venous, and the amount of the fluid also are edematous fluid also are visible in that slide. In next slide, on ultrastructural level, observed swollen endothelial cells, which is a closed the lumen of the capillary. And in addition, endothelial perivascular area occupied by edematous fluid. The slide, which I showed to you on electronogram, that is taken from the animals from the 30 days of the experiment. There are visible sign of fibrosis in perivascular area, which the lumen of the capillary endothelial cells, abundant pinocytic vesicles, microcytopodi also are visible, mitochondrion also are visible on the endothelial cell cytoplasm, basal lamina, which is surrounded it, and collagen fibers, which is arranged like bundles, that is a sign of the perivascular area fibrosis. In conclusion, summarizing the data on morphological alteration of endothelial cells at lung inflammation induced by intravascular administration of the macrophage migration inhibitor factor that influences the functional state of the organ should be considered in experimental lung pathomorphology and implemented to open up new treatment opportunities for recovering the integrity of endothelial barriers of lung vessels, especially microvessels. Also, result recommended using as a methodological basis in the treatment of pulmonary pathological disease. Thanks for your attention. Thanks for your patience, how you are listening to me. Thanks for participating in this conference. I appreciate my gratitude for organizing committee also.
Thank you, Dr. Alia, for your forward-thinking insight. I do have a question. How does macrophage migration inhibitory factor influence ultrastructural changes in the pulmonary vascular compartment?
Please, you repeat and loudly tell me your question, if possible.
How does macrophage migration inhibitory factor influence ultrastructural changes in the pulmonary vascular compartment?
Okay. Pulmonary vascular compartment we subdivided into two types: small capillary, small vessels, and medium large-sized vessels. Small vessels is influenced by macrophage migration inhibitor factor more deeply, but superficial alteration is happening in the large vessels. In the more deeply is directly influenced to aerohematic barrier. Capillary is dilated and the lumen of the capillary obstructed by the plaque of erythrocyte, thrombocyte, and plasmorrhagia is happening. It means permeated edematous fluid around vessels, around capillary, around precapillary arterial, around postcapillary venous. That edematous fluid is directly influenced to the lung tissue. And it's influenced to the functional state of the organ. But if it's in the small dose, if it's the small dose, it's like immunomodulator function, have macrophage migration inhibitor factor, because it stimulated immunocompetent cells to perform to preparing immune response.
Okay. Thank you. Thank you, Dr. Alia. Is there anyone else who would like to ask a question? Thank you, Dr. Alia. Next, we welcome Dr. Hadsa Sadeh from Managing Director at AstraZeneca Computational Pathology, joining us from Germany. She will speak on transforming diagnostics and treatment through computational pathology, a deep learning approach for precise biomarker quantification and patient selection. Kindly join me in welcoming her.
Thank you very much. I'm going to try and share my screen. I hope you can see my screen.
Yes, it's visible.
All right.
Yes, visible.
Perfect. I hope you can still see my screen. Sorry, I'm struggling a little bit with my screens today.
Yes, it's visible.
Perfect. All right. Good morning, good afternoon, everybody. My name is Hadsa Sadeh, and today I would like to take you on a short journey on how computational pathology can guide the treatment of the use of ADCs. And I lead the AZ Computational Pathology group based in Munich. And these are my disclosures. A variety of advanced technologies help us to identify and provide a comprehensive view of key biomarkers. And one of the technologies IHC is used to detect the presence and abundance of target proteins within tissue samples and helps in understanding of tumor biology. Not just tumor biology, but the tumor microenvironment, and in the diagnosis and guiding of therapeutic decisions. As the potential of AI continues to grow exponentially, we anticipate that computational pathology will fundamentally transform the landscape of IHC biomarker testing. And the acceleration for computational pathology came with advances in whole slide image acquisition that you see on the left-hand side of this slide. And these scanners, coupled with increased GPU throughput and sophisticated storage systems, have greatly enhanced our ability to process large data sets using AI. And pixel-level annotation inputs from domain experts drive supervised learning that you see in the second column. And the output is fully explainable, particularly advantageous for facilitating approvals. But as you can imagine, this is also extremely time-consuming and expensive. We also have weekly supervised learning, which uses image-level data, which is easier and cheaper to produce. However, the results are not entirely explainable, right? And this method needs humans to interpret risk heat maps visually. And self-supervised learning, particularly through foundation models that you see on the right-hand side of the image, is easier and cheaper to produce, although the results are not entirely explained. It focuses on understanding the general characteristics of pathology, images across varied domains, and while the representation of pixel patches are not directly interpretable, they act as efficient foundations for further applications. And this strategy drastically reduces the need for human input, facilitating scalable and effective diagnostic software development. And digital and computational pathology impact all stages of the patient journey, from initial screening to diagnosis and prognosis, with key benefits across all these stages. Two examples of improving pre-screening and prognostication, we can go to them in a little bit of detail. The first one I'm going to talk about is the MS Intuit. MS Intuit is an AI-driven pre-screening tool for MSI and colorectal cancer, answering the very simple question: detect patterns indicative of MSI using just H&E slides. It has high sensitivity and could reduce actually unnecessary reflex testing by up to 60%. And identifying MSI status in CRC can help predict prognosis and guide treatment decisions, especially regarding immunotherapy. And the second example I want to talk about today is Mesonet in mesothelioma, which applies machine learning to predict overall survival in whole slide digital images. And as mentioned before, we believe that AI-based technologies for new predictive biomarkers that guides treatment will support treatment paradigms like the ADCs. Coming to ADCs, as you know, ADCs have emerged as a transformative modality, combining the selectivity of monoclonal antibodies with potent cytotoxicity of small molecule drugs. Significant strides have been made in ADC development, leading to the approval of over 15 ADCs. However, the need for precise tissue-based biomarker technologies is critical to predict patient response and tailor ADC efficiency effectively. And this is where we believe that computational pathology-based assessment of IHC images adds on to quantify target expression objectively, precisely and reproducibly. And we do this using the AstraZeneca proprietary algorithm, which is called quantitative continuous scoring. And what is quantitative continuous scoring? QCS, or quantitative continuous scoring, is a fully supervised image analysis algorithm that can derive signatures predictive of clinical benefit and to deliver an explainable IHC biomarker. And QCS has two parts. The first part consists of the development of two AI models which act in tandem to analyze digitized images of immunohistochemically stained tissue samples. The first AI model is called ART. And what ART, or automated region segmentation of tumor, which you see in the circle with the green overlay, it identifies and distinguishes tumor cells from other components. And the second AI model segments individual tumor cells into membrane, cytosol, and nucleus, and quantifies the expression of the target protein in these compartments. And while the final workflow is completely automated, the development of these fully supervised AI models, both ART and SSTC, is heavily reliant on granular input provided by expert pathologists, as you can see in this slide. The pathologists provide the information by annotating fields of view in these images and also provide granular information for membrane and nuclei. And this, as I mentioned, happens in a three-stage process of model training, model validation, and model testing. And the second part of QCS is focuses on testing 7 human interpretable features derived at single cell resolution from the target quantification that happened in the first step and against clinical outcomes in patients. This analysis aims to identify features that are most associated with treatment benefit. And here are 3 examples of how the human interpretable features look like. And what you can see here, we have, if you're looking at the ADC mode of action, and what you can look at is target intensity or density. QCS enables the precise measurement of the expression, and this measurement can be visualized in different formats. One is the histogram analysis, where you can look at the percentage of positive cells relative to the number of all tumor cells in your sample. You can also look at the density of positive cells. You can look at medians and quantiles, and you can assign a certain positivity. The positivity can be assigned either by a functional threshold or by simply background staining or isotype matched control. And what we also do, what is important to note is we use mass spec quantification to provide ground truth of protein expression. And as you can appreciate, IHC is antibody dependent quantification, and mass spec is antibody-independent quantification. So we benchmark the antibody-dependent quantification by antibody-independent quantification. And as you can see in the data on the right, what you can see is membrane expression measured by QCS in an antibody-dependent manner, right, correlates with the HER2 expression levels derived from mass spec. And one more example I want to provide is data, and this is published, data from preclinical studies demonstrating that we can monitor and quantify the PK/PD of an ADC from IHCs using a QCS-based analysis. Our analysis in this particular example revealed a dose-dependent accumulation of AZD8205, which is B7H4 ADC, and in tumor cells over time, as visualized by a human IgG assay, first image from the top, which correlated with an increase in the positive staining of gamma H2AX foci, signifying induction of DNA damage, which is second image from the top, an elevated cleaved caspase-3, and a decrease in the epithelial density, the third and the fourth images from the top were observed over time in AZD8205 treated tumors compared to the control. And taken together, these data suggest that AZD8205 binds to B7H4 positive tumor cells, causing DNA damage and apoptotic cell death, consistent with our ADC mechanism of action. And the second example I want to talk to you about today is how QCS can delineate mode of action of ADCs. And especially where conventional IHC scoring has not predicted response, as in the case of TROP2 ADCs. And what QCS does is it addresses the limitation of visual scoring by precisely quantifying the TROP2 in the membrane and cytosolic compartments. And not only that, it also is able to compute the relative amount of TROP2 expression in the membrane and in the cytosol and vice versa. And the difference, which we call TROP2 normalized membrane ratio, or NMR, which is the amount of TROP2 in the membrane divided by the total number of TROP2 in the membrane and the cytosol, has proven to be very important for response to Dato-DXd or TROP2 targeting ADCs. And what we have seen is a sample is classified as TROP2 QCS or TROP2 NMR positive if at least 75% of the tumor cells exhibit an NMR of greater or less than 0.56. And this criterion signifies that the majority of tumor cells in the sample display an equal or slightly greater TROP2 cytoplasmic expression compared to the membrane expression. And as you can see, this data was presented at World Lung in 2023. In 2024. And here you can see in the biomarker evaluable population of the TL01 clinical trial, which is a randomized phase 3 clinical trial, open label, global study that enrolled patients with advanced or metastatic NSCLC with or without genomic alteration. TROP2 QCS NMR positivity was predictive for longer PFS with Dato-DXd, with a median PFS of 6.9 months in the QCS NMR positive group, compared with 2.9 months in the QCS NMR negative group. You can also see that the biomarker status did not impact the PFS observed with the standard of care, suggesting that TROP2 NMR status is predictive for Dato-DXd. And objective response rate was also higher for Dato-DXd in the QCS NMR positive group at 32.7%, compared with QCS NMR negative group at 16.9%. To conclude, computational pathology, particularly through QCS, offers an advanced approach to biomarker analysis, pushing the boundaries of what we can achieve in precision medicine. And these methods, computational pathology methods, not only provide a quantitative assessment of biomarkers, but also help to define new molecular signatures predictive of ADC activity, leading to enhanced patient outcomes. And with that, I come to the end of my talk. I want to thank the patients, the families and their caregivers in the mentioned clinical trials, and also the AstraZeneca and Daiichi Sankyo teams and the principal investigators on the TROPION-Lung01 clinical trial. Thank you once again to the organizers for having me here today, and thank you all to all the participants listening to the talk. Thank you for your attention. I'm happy to take any questions.
Thank you, Dr. Sabi, for your insightful presentation and your valuable contribution. My question is, how can deep learning in computational pathology improve precise biomarker quantification and enhance patient selection for targeted treatment?
I hope I was able to convince you today that if you use deep learning methods as you have used as we have used in this particular examples that I have shown today, you can, by precisely quantifying the target expression in the different cell compartments, you can have an AI biomarker that is able to delineate response to an ADC. So,
thank you. Is there anyone else who would like to ask a question? Thank you, Dr. Sabir. Next, we welcome Dr. Polenat Konstantinos from Moscow Clinical Scientific Center, Russia. He will speak on biomarkers in the era of personalized medicine, a revolution in the making. Kindly join me in welcoming him.
Can you see the slides?
Yes, it's visible.
Okay. First of all, I would like to thank the organizing committee for the honorary acceptance of my oral presentation, the fellow doctors that preside the session. My name is Konstantinos Folinas, and my oral presentation's title is Biomarkers in the Era of Personalized Medicine, a Revolution in the Making. We have come a long way from 1940s, where in order to fight cancer, we treat a patient with experimental or with experimental molecules, and also good results. And we have come to the last years of the 20th century, trying to combine modalities in trying to treat cancer. And we have come to our era of personalized medicine, where with new novel molecules or novel combination of molecules have risen from clinical trials or certain combinations, and also some biomarkers that have been validated through the years. And personalized medicine era has begun trying to use those biomarkers in order to find which subpopulation will benefit most from certain treatment with certain targeted therapy. In personalized medicine, the medical treatment is tailored by the individual characteristics of each patient, including genetic makeup, medical history, and lifestyle. Physician can identify specific mutations or genetic abnormalities driving a patient's cancer and prescribe targeted therapies. Immunotherapy can harness the power of immune system to fight cancer with personal medicine. We can help reduce side effects and improve the efficacy of treatments, leading to better outcomes for cancer patients. We can use precise and personalized care by improving the quality of life of the patient. And we use target therapy, it allows drugs to be designed specifically to target cancer cells while leaving healthy cells unharmed. But we have to go back to the basics and see what cancer biomarkers are. There are measurable substances, genes, proteins, or biological processes that can be found in a person's blood, tissue, or bodily fluids, which provide information about cancer. There are 7 types of biomarkers: susceptibility/risk, diagnostic, monitoring, prognostic, predictive, pharmacodynamic/response, safety. With predictive biomarkers, biomarkers determine if an individual is more likely to experience a favorable effect from a medication. A prognostic biomarker indicates the likelihood of disease recurrence or progression. A diagnostic biomarker can detect or confirm the presence of a disease. Susceptibility biomarkers indicate the possibility of developing a disease for a healthy individual. Pharmacodynamic biomarkers identify individuals' response to medication. Safety biomarkers indicate an adverse effect measured before or after exposure to medication. And monitor biomarkers can assess the status of a disease or medical condition. As far as prognostic biomarkers are concerned, we use these tumor markers in our everyday clinical practice in certain carcinomas. But this is how we see biomarkers, because for a patient, these biomarkers are a source of anxiety. Either they're followed up, they're followed up, or they receive some kind of therapy. And it seems to be like a Damocles sword pending upon the patient's head, trying to harm the patient. And this is our role, to make the patient, to explain to the patient that the tumor markers are circumstantial evidence and not direct evidence which is the result that are the results of imaging modalities such as CT, MRI, PET-CT, so on, that we use in according to what the follow-up or
Dr. Solinas, can you kindly share the slide?
what?
Can you kindly share the slides, please?
I do share the slide.
Can you share the slides, please?
Can you see the slide now?
Yes, it was visible earlier also, but can you?
Can I continue?
Yes, please continue.
Okay. As far as predictive biomarkers are concerned, in colorectal cancer, we can use genomic alteration related markers, DNA-related biomarkers, peripheral blood biomarkers, and we can use gut microbiome analysis that can serve as a promising non-invasive biomarker by detecting cancer and by predicting the efficacy of immunotherapy, and by identifying specific molecular signatures such as Fusobacterium nucleatus in colorectal cancer. And the species of microbial microorganisms can correlate to tumor development, inflammation, and treatment efficacy. We do know, we are all familiar with current biomarkers in NSCLC. We know a few emerging biomarkers such as STK11 and KEAP1 that inform us how cold or hot tumor is as far as immunotherapy is concerned. And we have certain biomarkers that can guide us through the therapeutic algorithm in certain settings and in certain lines. In breast cancer, we use HER2 and endocrine receptor in order to classify this heterogeneous carcinoma. And these are some biomarkers that are used in immunotherapy as far as tumor cells, tumor microenvironment, circulating factors, host-related markers, immune-related adverse events are concerned. But we're not as lucky in other carcinomas, such as small cell lung cancer that has a dim prognosis. And there's a lot of research in that field, in that carcinoma, and that research has given us 4 major subtypes of small cell lung cancer with distinct therapeutic vulnerabilities. And this by using heat maps. And with the use of these heat maps, we have identified 4 subtypes: SLC-A of ASCL1 driven SLC-A subtype in 50% of the cases with high neuroendocrine differentiation. We have neuro D1 driven SLCN subtype in 20% of cases with lower neuroendocrine expression. We have POU2F3 driven SLCP in 10 to 15% of the cases with no neuroendocrine expression. And we have SLCI inflamed subtype that has no neuroendocrine expression and is characterized by expression of certain genes in immune cells. But these heat maps are not a biomarker. But yet we have established a connection between certain subtypes and the ability to use certain target agents, such as DLL3 agent in SLCA, and who knows, in the future we can give to these patients that have a certain subtype a certain drug such as tarlatamab that was recently FDA and EMA approved. But we have other problems in some trials. In positive trials also, such as Clarity trial, where in patients that had cholangiocarcinoma, and we saw in the use of ivosidenib, there were responders, but we can't predict what would be the responders besides the mutation of IDH1. But there are some new trials like Calypso trial, a phase 2 study investigating sabolitinib in combination with durvalumab in advanced papillary renal cancer that used ctDNA test at baseline, week 4 to 16, and at progression of disease. And we saw that ctDNA was correlated, the ctDNA positivity in baseline was correlated with shorter OS. In a dynamic 3 study design that was a 5-2 to 3 phase study for patients with stage 3 colon cancer that underwent surgery with Rho0 resection, and they were randomized either to take the standard treatment blind to ctDNA result or to take ctDNA informed management, and according to the result, with a ctDNA negative, the patient could de-escalate the 6 months of FOLFOX to either no chemotherapy or 3 months of FOLFOX, or to ctDNA positive patients to escalate and take 6 months of folks. And this trial, we saw that ctDNA was a robust biomarker in the setting of adjuvant therapy in the stage 3 colon cancer. Also, we have IMvigor 011 study design for patients with muscle invasive bladder cancer within 6 to 24 weeks of radical cystectomy. They were surveillanced by ctDNA monitoring up to 1 year, and if they were ctDNA negative, they received no treatment. And if at any time they became positive as far as the ctDNA test was concerned, they were randomized to one to receive atezolizumab or placebo. And we saw that the ctDNA had a strong prognostic was a strong prognostic biomarker for a patient post cystectomy. As far as carbonic anhydrase 9 PET CT imaging was evaluated as a biomarker in clear cell renal cell carcinoma. And the results were represented in ESMO 2025. And we saw that it was correlated with the PFS of the patients. Also, computational histology, artificial intelligence, CHAI, prognostic biomarker in renal cell carcinoma. Also, we saw that it was also it had a correlation with PFS. And a post-hoc analysis of CheckMate 214 presented at SCOT GU 2025 for treatment naive and inoperable locally advanced or metastatic RCC. We had the patients were randomized to take either nivolumab plus ipilimumab for 4 doses and then nivolumab for every 2 weeks versus sunitinib, 4 weeks on, 2 weeks off. And in this trial, with the post-hoc analysis, kidney injury marker 1, KIM1, was evaluated as a prognostic or progressive or predictive biomarker. I'm sorry. And the results were that a positive or high levels of KIM1 in baseline was correlated to shorter OS. And in these patients, the decrease of KIM1 from baseline to 3 weeks resulted to prolonged PFS. As far as the future of biomarkers are concerned, we have AI and big data that will play a crucial role in identifying patterns, complex biological data, improving the accuracy of biomarker discovery, enhancing imaging-based diagnostics. As far as liquid biopsies are concerned, they are the future of cancer biomarkers due to their non-invasive nature and their ability to perform multi-omics analysis on a single blood sample. About the multi-cancer early detection tests, we seem to aim to identify multiple cancer types from a single sample, potentially transforming scientific programs, especially in cancer that lack effective detection methods. As far as further steps in personalized medicine, there is a transition to a patient-specific profile created by a multitude of biomarkers that will result in more personalized treatment plans and better predicting a patient's response to a specific therapy. About advanced analysis, research will move beyond single markers to use multi-omics tests that will combine information from different types of biological data, genomics, proteomics, metabolomics. And last but not least, novel sources, where the industry is growing in non-invasive sources like saliva for biomarker detection, although challenges remain in sensitivity and specificity for certain applications. Thank you very much.
Thank you, Dr. Paulina, for your informative session. My question is, how are biomarkers driving the shift toward personalized medicine in modern healthcare?
Could you please repeat?
How are biomarkers driving the shift toward personalized medicine in modern healthcare?
This is, I think this question was explained in the last part about the future of biomarkers, because we can use all of these tools that are at our disposal, or they will be with the use of artificial intelligence, radiomics, and all the other omics that will give us further tools in order to optimize our treatment and make more personal treatment of the patient, and not giving a patient a certain combination of molecules and trying to see what will be the benefit.
Is there anyone else who would like to ask a question? Thank you, Dr. Paulina.
Thank you very much.
Now, our next poster presenter is Dr. Vero Parvayana from Moscow Clinical Scientific Center, Russia. She will present on cytological diagnosis of secondary lymph node lesions in breast cancer.
Hello.
Dr. Yana.
Good afternoon, dear colleagues and dear chairs. I would like to present to you with my report on this topic, cytological diagnosis of secondary lymph node lesions in breast cancer. According to the Russian Cancer Registry, breast cancer is the leading cancer in women in 2024, accounting for 22.4% of all newly diagnosed cancer.
Dr. Yana, could you please be a little louder?
Sorry?
A little louder. A little louder. Dr. Yana, could you please be a little louder?
Can you see my end here?
Yes, yes, we can hear you. Yes, we can hear you. Go ahead, please.
The aim to evaluate the effectiveness of the cytological method in detecting breast cancer metastases. From January to December 2025, 2,787 5-needle aspiration biopsies of axillary lymph nodes were performed at the Loginov Moscow Clinical Research Center. Of these, 449 cases also had a histological examination, and the average age of the patients was 65 years. The results of the cytological examination revealed the absence of malignant cells in 73.7% of cases, the suspicion of the presence of malignant cells in 4.3%, and the presence of malignant cells in 22%. In all cases, a cytological histological correlation was performed with a total diagnostic accuracy of 92%. False positive results included 90 cases. False negative results were obtained in 70 cases. I would like to present several clinical cases that have been identified as discrepancies in our practice. A 65-year-old woman with a mass in the upper outer quadrant of the breast and a single mass in the axillary region. In the material obtained from the axillary lymph node, single scattered and clustered cells with glandular differentiation and enlarged nuclei with sling polymorphism were found in the background of lymphoid elements of various degrees of maturity. Cytological picture of adenogenic cancer metastasis to a lymphoid node. According to the histopathologist report on the metastasis to the left axillary lymph node of an invasive carcinoma with a signs of glandular differentiation. The next clinical case. A 69-year-old woman complained of discomfort in her left breast. An ultrasound examination revealed in isehoic a vascular mass measure 80.5 x 5.9 millimeter at the border of the lower quadrants, as well as an enlarged axillary lymph node. Here you can see clusters of the cells with abundant cytoplasm and rounded, slightly enlarged nuclei surrounded by blood element and fat drops. According to histopathology reporting, invasive non-specific breast cancer with apocrine differentiation features. Our data included that the cytological method for detecting metastatic lesion in lymph nodes in breast cancer is effective and can be used to assess the staging of the disease. This is our friendly team, and thank you for your attention.
Thank you, Dr. Yana, for your insightful speech. Is there anyone who would like to ask a question? Thank you, Dr. Yana.
Thank you.
It is my pleasure to introduce Dr. Khan Umayya Afrin, Department of Pathology, Kamene, Academy of Medical Sciences and Research Center, who will be joining us from India. She will be presenting ovarian collision tumor composed of adult type granulosa cell tumor and serous cyst adenoma presenting with acute hemiperitoneum. Kindly join me in welcoming her.
Hello. Can you hear me?
Yes, we can hear you.
Okay. Give me a second. Good afternoon. So I'm Dr.
Can
Khan
you
Umayya
please be a little
from...
louder?
Hello. Can you hear me now?
Yeah. Yes.
Okay, so I'm Dr. Khan Umayya from India, Kamini Academy of Medical Sciences. I'm an assistant professor and I also work as consultant pathologist. So today I'm presenting a paper which was presented as a rare clinical condition which has a collision tumor of the ovary which has presented as ruptured hemorrhagic ovarian cyst with hemoperitoneum. Introduction. Collision tumors are defined as coexistence of two histologically distinct neoplasms occurring in the same organ without histologic admixture. And these tumors arise independently, which are separated by a clear interface. Ovarian collision tumors are rare and often they mimic a single neoplasm clinically and radiologically, posing a diagnostic challenge. Accurate diagnosis is required. Careful cross-examination and thorough histopathological sampling, as each component has different prognostic and management implications. So here I am presenting a case summary of my case where there was a 50-year-old female presented with sudden onset, severe abdominal pain, abdominal distension, and giddiness of 1 day duration. On examination, the patient was in shock with tachycardia and hypotension. On laboratory investigation, it was revealed that patients have severe anemia with hemoglobin of 4 gram per deciliter. And on further evaluation, radiological imaging was done. It showed that there is a large heterogeneous solid cystic pelvic mass with ascites, and there was suspicion of ovarian neoplasm. And with these findings, the surgeon has done the exploratory laparotomy, which revealed that there is a hemoperitoneum with a ruptured hemorrhagic ovarian cyst and bilateral ovarian masses. Because since there was this masses, the cystectomy with ovarian cystectomy with bilateral sarcopharectomy procedure was done, and the specimen was sent to us to the Department of Pathology for histopathological examination. These were the radiological findings. On contrast CT enhancement. There was a ill-defined mass here, which was approximately 13 into 15 centimeters, and which showed the both solid and cystic components. And the lesion was extending also into the lower abdomen, and there was a displacement here. We can see that there is displacement of the adjacent bowel loop, and there was also a moderate free fluid in the abdomen and pelvis. Here there is a image which showing the post-contrast enhancement with focal loss of fat planes, and there is adjacent structures raising suspicion for an ovarian. It is also pushing the adjacent structures here, where is raising the suspicion for malignancy. And uterus and ovaries was not visualized separately. Then intra-op findings, the emergency exploratory laparatomy revealed that there was approximately 2 liters of hemoperitoneum with large clots in the pelvis, and there was 10 into 7 centimeters ruptured hemorrhagic cyst was identified in the right ovary with active bleeding in the cyst cavity. So it was that cyst was almost like it was ruptured and there was active bleeding. Then the left ovary showed a 6 into 5 centimeter cystic lesion which contained the clear fluid. So one ovary was with a ruptured hemorrhagic cyst, and the other ovary was showing the 6 into 5 centimeter cystic lesion, which was just clear fluid. It was not hemorrhagic. Then the uterus was absent, the status post-hysterectomy because of the post-hysterectomy status, and peritoneal lavage was performed, and bilateral sarcopharectomy was carried out. The specimen sent for histopathological examination. This was the ovary, which this left ovary, which is showing the left ovary, which is showing the clear fluid and the benign serous cyst adenoma, and this is the another ovary, right ovary, which shows this two components here, and this is hemorrhagic ruptured area, ruptured surface area, which is showing the hemorrhagic component. The gross findings were ovarian mass with both hemorrhagic and solid components. Mass was measuring 10 into 7 centimeters with areas of rupture and adherent blood clots. Cut section revealed solid hemorrhagic areas with cystic spaces containing clear fluid, and cyst wall was thin, smooth, without obvious papillary excrescences. Then representative sections were submitted for both components for histopathological examination. In the microscopy, we saw the revealed two distinct tumor components within the same ovarian lesion. One component showed the adult granulosa cell tumor, and the another component was serous cystadenoma. And both of the tumor had this sharply demarcated with an abrupt transition and no histological admixture. I'll show you here. There is the low power image showing the cyst wall. This is the cyst wall which is lined by the single layer of the flattened to cuboidal epithelium. Underlying there is the fibrous stroma, and there is no epithelial stratification or atypia or any mitosis here. So it is a benign serous cystadenoma component. And this was another area in the same cyst where it was showing a cellular ovarian tumor, which is composed of sheaths and cords, which showed this uniform cells which are embedded within the cyst wall. See here on the surface, we can see there is a single lining which has shown which is showing the partly eroded cyst wall. And in the subepithelium, there is this infiltration of the small uniform cells which are embedded in the stroma, which is the granulosa cell tumor component, which is showing the areas of hemorrhage. This is the low power image showing this granulosa cell tumor composed of this sheaths, cords, and small uniform cells, which are separated by this delicate stroma. This is the adult granulosa cell component. And on the same picture in the high power, we are seeing the tumor cells which are scant in cytoplasm and round to oval nuclei. And if you can see here, there are some of the cells show this coffee bean appearance of the nuclei, which is central with a coffee bean slit in the nucleus, so which is giving the appearance of a coffee bean nuclear grooving. An occasional microfollicular arrangement is also seen here. These are the features of the adult granulosa cell tumor. And on the immunohistochemistry, this is the immunohistochemistry marker, which is specifically positive for granulosa cell tumor, inhibin. So we have done the inhibin on the sections of this tumor, this lesion. So it was highlighting this granulosa cell component on this, whereas on the surface you see there is a single flat lining with it was negative, and on the stroma of the cyst wall there is this infiltration of the cells which is showing the positive for inhibin positivity. That is, we have confirmed the existence of two, that is benign serous cystadenoma component and granulosa cell tumor component in the same cyst of the ovary. Final diagnosis, we have given it as collision tumor of ovary composed of adult granulosa cell tumor and serous cystadenoma. Both components were present within the same ovarian lesion with abrupt transition, as we have seen in the images, and there is no histological admixture, which is consistent with the collision tumor. Discussion. Ovarian collision tumors are rare and which are characterized by coexistence of histologically distinct tumors within the same ovary. Radiologically, these lesions often present as complex solid cystic masses, and these can mimic ovarian malignancy as seen in the present case. So most reported ovarian collision tumors involve the combination of mostly we see the mature cystic teratoma component and the mucinous tumors. But this sex cord stromal tumors with the epithelial tumors is a really rare. I have seen only one case which was published previously. And I think this is the second case which is published as a sex cord stromal tumor, which is a granulosa cell tumor and with the serous cystadenoma. So it is like around very rare with less than 10% of the tumor. Few studies have reported rare associations, including adult granulosa cell tumor with the mucinous or serous cystadenoma, emphasizing the importance of extensive sampling. So, whenever we are seeing a complex ovarian cyst, we have to gross it extensively and give the extra sections to rule out the dual malignancy or any dual tumor component in the cyst. Similar to previously reported cases, the present case showed a complex mass which is radiologically suspicious for malignancy, and while histopathology demonstrated two distinct tumor components with abrupt transition, which is confirming a collision tumor. Conclusion: ovarian collision tumors are rare lesions which are composed of two histologically distinct neoplasms within the same ovary. Radiological findings may mimic malignancy. As we have seen in our case, there was a solid and cystic component. It was like pushing the structures surrounding like intestine, bowel, and the surrounding soft tissues. So it is giving radiologically, it was mimicking as a malignancy, which is leading to the diagnostic uncertainty. Careful cross examination with adequate sampling is essential for accurate diagnosis, which helps guide appropriate management and prevents overtreatment. Thank you. This was my presentation.
Thank you, Dr. Ramaya. My question is, what are the key challenges in diagnosing and managing ovarian collision tumors with acute hemoperitoneum?
See, if the patient is presenting with the acute hemoperitoneum, so first a patient has to be in a center, in a approachable to the hospitals where patient can be taken very quickly to the hospitals where they can be managed. Here in India, we face that difficulty where there is a delay in the diagnosis of such patients, because till they go to the hospital, they don't with the symptoms, they sit with the symptoms, and they think that when they go to the like not qualified enough to like they go to the physician and they take some tablets and they think that it will subside, but actually the patients reaching to the appropriate surgeon to get them operated, that is first challenge we face here in India. That that is the thing first we think. And if the patient reaches to the surgeon or the initial workup and all, they have to be at the on point because these are the really bleeding in the hemoperitoneum. All these things are it has to be like really quick. So if then after that the patient should also be the appropriate investigation should be done on time, and after that if the patient is surgery has done, then appropriate post surgical management should also be again a challenge, because these patients can undergo shock and lead to secondary complications like heart multiple organ failure. So the post operative care is also very important in these cases where they are presenting with such huge hemoperitoneum where the hemoglobin is going up to 4 and 3. We are seeing these cases, and then more than a primary thing, they succumb to the secondary complications like bleeding and infections, shock. So these also post-operative care is also important. Then after post-operative care, the challenge is appropriate diagnosis. The sampling, the organ whichever is taken on, like the ovary, if it is not sent to the proper surgeon, a pathologist, a well qualified pathologist. Here we face another challenge where the lab is maintained by some underqualified person and they are not doing the proper sampling. Then it goes unnoticed. They'll diagnose it as some hemorrhage and there is some benign cyst. It is left like that. But we have grossed it. We have had a suspicion of, since there is some cellularity is more, the wall is infiltrated by something. Okay, let's take some more sections. Then we have taken some more sections. We have appropriately grossed it. We have done the regrossing of this tumor. Then we have found that, oh, there is another component, and we have confirmed it by the immunohistochemistry. So this is another challenge where should be a qualified person, qualified pathologist, a person with well established knowledge in pathology, histopathology, where we are doing, we have to be some few samples. Okay, we can ignore like if it is normal benign thing, but these are the granulosa like intermediate lesion. It is not a completely malignant, but it is an intermediate malignancy. So it has to be it has to be done a proper resection and all. The patient should be followed up in the later years so that the recurrence should not happen. So we have contacted the surgeon, or we have informed him that there is a two different malignancies in the same ovary. So they are not taking the appropriate follow up and the care of the patient. So that is another challenge. I think it should be in the proper hands in the proper correct time.
Thank you. Thank you, Dr. Ramaya. Is there anyone else who would like to ask a question? Thank you, Dr. Ramaya. Our
Thank
next
you.
poster presenter, Dr. Waheem Mohammed Ahmed, consultant histopathologist in Stockport NHS Foundation Trust from the United Kingdom. She will present on cervical carcinosarcoma, a rare aggressive tumor. Kindly join me in welcoming her.
Hi, thank you very much. So I'm just going to try and share my screen. Sorry, I'm not sure why it's not sharing. Hello, can you hear me?
Yes, we can hear you.
You can hear me. Okay, that's good. I'm just struggling with sharing my screen for some reason. Sorry, I might have to just exit and come back again. Is that okay?
Yes, that's perfectly okay.
I'm so sorry about this. Okay, I'll be on. Hi, so can you hear me now?
Yes, we can hear you.
Okay, excellent. And can you also see my screen?
No, it's not visible.
Not visible, okay. Keep trying. Can you see it now?
Yeah, visible.
We got there. I'm so sorry about these technical issues. So hi, good afternoon, everyone. My name is Wiam. I'm a consultant pathologist based in Manchester in the United Kingdom. So it's really great to see people from all over the world today sharing their expertise. So thank you very much for having me. I'm here to present our poster also on behalf of Dr. Raj Saravana. So I hope that you find it useful. So a very quick introduction first. So I'll be presenting a case on cervical carcinosarcoma, which is unfortunately a very rare but also a very aggressive tumor with less than 150 cases reported worldwide. Now, due to the small number of cases that have been reported and studied, unfortunately, there's very limited data and guidelines on how to best tackle these very aggressive tumors and what the prognosis is likely to be. Although all the reported cases, or almost all the reported cases so far, have had very poor prognosis. So I will discuss why our case in particular was quite unique and how a multidisciplinary team approach was crucial to make diagnosis. Right now, so she was 81 years old and she presented to her GP with a 3-week history of postmenopausal bleeding. Now, the patient was urgently referred to the gynecology team. Now, the gynecology clinician, on speculum examination, the clinician described that there was a large tumor on the surface of the cervix. Now, the tumor was so large that it was actually obstructing the cervical os and making it very difficult to enter into the endometrial cavity. So at this point, the clinician wasn't really very sure whether this was a primary cervical or endometrial carcinoma. So a biopsy was taken and urgently sent to us in pathology. So now discussing the histology or the biopsy. So I always find it actually easier to explain things in pictures. So I'm hoping it's projecting quite well for you. So even on very low power, we could see that the tumor was a very high grade malignant neoplasm. But there was also 2 very distinct components. So first of all, we'll discuss component A, which you can see here. So this part, it was nests and syncytial sheets of these highly atypical cells, but they were also very pink. And on close examination, you can see that there was keratinization. So in this instance, the first thing we thought about is squamous cell carcinoma, which is a very common malignancy of the cervix. But when we looked closer, there were also these surrounding fragments, as you can see here, the more blue, darker fragments, and this is a zoomed in picture. And this component was very different. Now, the cells were also highly atypical, but they were also very pleomorphic, they were bizarre formed, almost all of them were spindled, and there was lots of atypical mitosis and lots of necrosis as well. So this component looked very different and it almost looked sarcomatoid. Through histopathology fashion, we carried out immunohistochemistry taken proof the morphological diagnosis that we were seeing. So here on the left hand side, on the bottom corner, so this stain was P63. Now, P63 is a squamous marker, and we also carried out a few others, such as P40 and CK56. Now, all 3 squamous markers were very strongly positive in this squamous looking component. So it confirmed what we were seeing on the H&E slide. Now, this sarcomatoid component was completely negative, not only for the squamous markers, but also for cytokeratins. Again, this was more in keeping that this is a different sarcomatoid component rather than a poorly differentiated carcinomatous component. The other immuno that we also found semi-helpful was P16. which is on the right-hand side. Now, P16 is used as, it can be used as a surrogate marker for high-risk HPV infection, which is the main driver for most cervical carcinomas. Now, this pattern of block positivity, where almost all the cells are nicely positive, this is seen in HPV-associated cervical squamous cell carcinoma. But just to confuse things, this pattern of staining can also be seen in very high-grade neoplasms, which this definitely was. So we also wanted to carry out other markers, or we already did carry out other markers, to try and classify the sarcomatoid component. So as I said before, it was negative for cytokeratins, negative for the squamous markers, but also actually negative for most other markers to help differentiate it. So for example, like vascular markers like CD31, CD34, it was negative for smooth muscle. So it showed very patchy positivity for SMA, which is a smooth muscle antigen, but it was negative for things like desmin, HCAL-desmon, and skeletal muscle markers, so like myogenin and MyoD1. So at this point, we could clearly see there's two components. There's a carcinomatous squamous cell carcinoma component and also a sarcomatoid component. So this biphasic nature of the neoplasm confirmed to us that this was a carcinosarcoma. Now, the issue really came when we were trying to decide where the primary site was. So we know cervical carcinosarcomas are very rare, but endometrial carcinosarcomas are much more common. So histologically, we found it very difficult to differentiate. So we really had to rely on the radiology to be able to help the clinicians identify where the primary tumor is. So I'm not very confident, but I can tell you that our radiologist explained that this is a sagittal section from the patient's MRI scan. And essentially, we have the vaginal canal here, got the cervix here, and this is the uterine body. So where the arrow is, very helpfully done by our radiologist, this was the center point of the tumor, so which is exactly where the cervix is. So the radiologist explained that actually they think that the primary tumor was here in the cervix, and it was extending upwards towards the uterine body, but also to the pelvic side walls and the parametria, and there was also a few positive pelvic lymph. A CT scan was also carried out, and it showed that it excluded distant disease. So the overall provisional FIGO stage was 3C1. Now, sitting together in MDT, so combining the clinical, the radiological findings, and histological findings, we decided that this is most likely a cervical carcinosarcoma, and the oncology team were happy to take over the patient to provide radiotherapy and pelvic radiotherapy and brachytherapy with continued imaging to see how the progress, if she was making progress. So really, the learning points of, or the conclusion, or I like to call them learning point of this case, is that although squamous cell carcinoma is the most common malignancy of the cervix, cervical carcinosarcoma is very rare, but we shouldn't be shy of diagnosing something just because it's a very rare diagnosis, especially when you have lots of evidence backing that up. So one of my favorite things about, I think, practicing in the UK is so this is where the all different, so the radiologist, everybody from different specialties come together, and they provide their expertise and within their specialties to provide the input in the patient's case. And we kind of all work together to ensure that the patient has the best possible treatment and overall outcome. So really teamwork is essential, especially in these complicated rare tumors. References, and also, sorry, I forgot to add a special thank you to Dr. Sudha Desai, who was the expert, gynae expert, our local gynae expert, who helped us in making this diagnosis also. And that's it. Thank you very much. If there is any questions, I'm happy to take them.
I have a question, possible.
Yeah, sure.
So you said rightly it's very rare tumor. I'm from Melbourne, Monash, in Australia, and I do gynae as well. So the P16, you're right, is positive as well in many high-grade tumor, including sarcoma. My question, did you do ISH on this one to confirm it's HPV related or not?
No, we didn't actually. And that I think that's something in retrospect when we discuss this case that we would like to do, just because it will be a bit academic because unfortunately the patient is progressing and she has stopped her treatment. But I think it will be very interesting to figure whether this is HPV driven or not.
Because that will be my next question. If it's HPV driven, will be different prognosis from the traditional carcinosarcoma, but from what you're saying, it's aggressive and behaving like normal carcinosarcoma.
Yes, unfortunately.
Okay, thank you.
Thank you. No, thank you.
Thank you, Dr. Ahmed. My question is, what are the current treatment strategies for this rare aggressive tumor?
No, that's a very good question. So unfortunately, as I mentioned in the start of the presentation, that due to these tumors being very rare, there hasn't been any specific studies for cervical carcinosarcoma, especially ones that have squamous cell carcinoma as the carcinomatous component. There hasn't been any studies to really determine what's the best way to treat these tumors. So currently, they're being treated very similarly to endometrial carcinosarcomas. But I mean, this is kind of one of the pivotal really points of this poster in this talk, is that we do need to kind of be able to identify these tumors, and not only identify them, but study them a lot more. So as my colleague just mentioned, kind of researching, doing ISH and identifying whether these are HPV driven or not. And if they are HPV driven, are there certain things that we can give these patients to give them better treatment and better prognosis? So we know things like that are HPV driven, for example, in the head and neck, they have much better prognosis than HPV independent tumors. So really, to answer your question, I think a lot more research needs to be done to be able to determine or give certain guidelines that particularly target these tumors to hopefully give patients a better outcome.
Thank you. Thank you, Dr. Zahid.
Thank you very much for having me.
Thank you. Next, we have Dr. Matis Koma, leading scientist at the Department of Pharmacology Medical Faculty from Slovakia. He will present on tetracycline enhances the cytotoxic efficacy of FOLFIRINOX and GEM-PAC in pancreatic ductal adenocarcinoma cell model. Can you join me in welcoming him?
Hello, everyone. Do you hear me?
Yes, yes, we can hear you.
Okay. Thank you for my waiting for fixing my problems. I would like to present my poster, which is called Tigecycline enhances the cytotoxic efficacy of FOLFIRINOX and GEM-PAC in pancreatic ductal adenocarcinoma cell models. Do you see my presentation?
No, it's not visible.
Okay, hold on a second.
Yes, it's visible now.
Okay, so is it okay now?
Yes, yes, you can continue.
Okay, So this is basically an in vitro study, small study. So let me introduce some wide-known facts about the pancreatic ductal adenocarcinoma. It remains one of the most aggressive malignancies characterized by late diagnosis, resistant to therapy, and poor prognosis. And despite the clinical use of combination chemotherapy such as FOLFIRINOX and gemcitabine plus nab-paclitaxel, the survival improvements remains limited, as you see in brackets. So it emphasizes the need for novel therapeutic approaches. And the tigecycline, a glycylcycline antibiotic, has recently attracted attention for its ability to inhibit mitochondrial translation and impair cancer cell metabolism, offering potential as an adjuvant chemotherapy. Well, the aims and methods used in our study were as follows. The study evaluated the impact of tigecycline in combination with FOLFIRINOX or GEMPEG in PDAC cell models. We used 4 pancreatic cell lines treated with standard regimens in molar ratios according to clinical practice, and either alone or in combination with tigecycline for 72 hours. Cytotoxic and antiproliferative effects were assessed by MTS and BRDU incorporation assays. In addition, the 3D spheroid models were established from the PANC and PATU cell lines to better mimic the in vivo tumor conditions, and treatment responses were evaluated using the cell titer glow 3D viability and spheroid size measurement. So I would like to save more time for the actual results, which are pretty nice. So to assess the impact of tigecycline cytotoxicity of standard PDAC chemotherapy regimens, we used the 4 pancreatic cell lines treated either alone with FOLFIRINOX, which is the A part, or the GEMPEG, which is the B part, in combination with tigecycline, which is blue colors, or without the tigecycline, which is in the yellow color. Treatment with FOLFIRINOX alone resulted in a reduction of cell viability only at high concentrations across the tested cell lines, indicated limited sensitivity to this regimen under standard conditions. Similarly, the GEMPEG treatment displayed only modest cytotoxicity with a significant reduction in viability observed in primarily CAPAN cell lines and PATU, whereas the PATU-PANC and MAIA-PACA cells remain largely resistant. The addition of tigecycline markedly enhanced the cytotoxic responses to both regimens. In combination with FOLFIRINOX, tigecycline significantly decreased cell viability at multiple concentrations in all tested lines. When combined with the GEMPEG, the tigecycline converted otherwise chemoresistant cell lines like PATU, PANC, and MAIA-PACA into more chemosensitive phenotypes, leading to substantial loss of viability. To further assess the effects of tigecycline on cell proliferation, we used the BRDU, which is bromouridine incorporation assay with the same conditions. In panel A, you see the FOLFIRINOX treatment. Panel B, you see the GEMPEG treatment. And in yellow, there is a standard regimen without tigecycline, and in blue, you see a combination of standard regimen with tigecycline. Consistent with the viability measurements, treatment with FOLFIRINOX resulted in measurable dose-dependent reduction in proliferation in MAIA-PACA and CAPAN cells, particularly at higher concentrations. In contrast, the PATU and the PANC cells demonstrated relative resistance, showing minimal proliferation decrease even at elevated doses. Tigecycline alone had minimal effect on DNA synthesis across all cell lines. However, when combined with FOLFIRINOX, a further reduction in proliferation was observed, most notably in PATU and MAIA-PACA cells. In PANC and CAPAN2 cells, this enhancement remained modest. Under GEMPEG treatment, PATU, PANC, and MAIA-PACA cells display substantial sensitivity, with reduced proliferation observed even at the lowest tested concentrations, while kappa-2 cells followed a more gradual dose-dependent response. The addition of tigecycline further reduced BRD incorporation across all GEMPEG-treated groups. However, similar to FOLFIRINOX condition, this effect represented a viable trend rather than a consistently statistically significant enhancement. To further assess treatment efficacy under conditions that better mimic the in vivo tumor architecture, the 3D spheroid models were generated from two PDAC cell lines, PATU and PAC. The other cell lines were not used because it was a bigger challenge by the time we were performing the study. Now we are working on different ways to produce the spheroids, and we get better results with all 4 cell lines. So I will present only the results from the 2 that were successfully created at the time of the performing of the study. So the compact and stable spheroids were successfully generated from PANC and PATU cells. In contrast, by that time we produced only loose aggregates that disintegrated upon manipulation with the other 2 cell lines. FOLFIRINOX treatment induced a reduction in viability only in PANC spheroids, and this effect became apparent only at higher concentrations, whereas the PATU spheroids remained largely resistant across the tested range. Tigecycline alone resulted in a modest decrease in viability in both cell models. However, this reduction was observed as a trend and did not reach statistical significance. When combined with FOLFIRINOX, tigecycline produced a significant viability decline in PATU spheroids, while the effect in PANC cells remained limited and did not differ substantially from FOLFIRINOX alone. In contrast, GEMPEG treatment reduced viability in PATU spheroids in dose-dependent manner. PANC1 spheroids demonstrated a more resistant response profile. Importantly, co-treatment with tigecycline markedly potentiated the effect of GEMPEG, resulting in a substantial decrease in viability across all tested doses. These findings indicate that tigecycline exerts a synergistic effect with GEMPEG, particularly in metabolically active 3D PANC models, while its impact in combination with FOLFIRINOX remains comparatively modest. We also tested the spheroid area and tested a spheroid growth dynamics that way. So the spheroids from PATU and PANC cells were exposed to the same conditions under FOLFIRINOX treatment. Under FOLFIRINOX treatment, PATU spheroids showed a dose-dependent reduction in expansion, while PANC spheroids remained largely unresponsive, indicated resistance across most tested concentrations. Tigecycline alone resulted in spheroid growth reduction in both cell lines, reaching statistical significance in PATU spheroids. Notably, combining tigecycline with FOLFIRINOX further suppressed spheroid growth with a significant effect observed only in PATU spheroids, whereas the PANC spheroids again showed limited sensitivity. Similarly, GEMPEG treatment displayed a dose-dependent inhibition of spheroid growth in PATU cells, while PANC spheroids remained high growth rates, indicating chemoresistance. Remarkably, co-treatment with tigecycline profoundly impaired the PATU spheroid expansion, effectively halting growth even at the lowest concentrations of GEMPEG. Together, these results confirm that tigecycline exerts a measurable chemosensitizing effect in 3D PDAC models, most prominently in PATU spheroids and particularly under GEMPEG treatment. So in conclusion, the tigecycline effectively increased the anti-tumor activity of FOLFIRINOX and GEMPEG in PDAC cell models, and these findings support its potential as chemosensitizing agent and provide a foundation for future preclinical evaluation of combined mitochondrial targeted and cytotoxic therapies in pancreatic ductal adenocarcinoma. So I would like to thank you for your attention and my colleagues that also supported this work and the government which funded this particular work.
Thank you, Dr. Madhu. I have a question. How does tigecycline enhance the efficacy of FOLFIRINOX and GEMPAC?
It's a good question. First of all, this study is a continuation of previous findings, not our findings. We are working on something slightly different. We are trying to isolate the fibroblast from the pancreatic ductal adenocarcinoma. And by searching the literature, I found out that the tigecycline impairs the mitochondrial metabolism in PDAC cell lines, and it was tested in gemcitabine treatment alone. So our idea was to extend on this data, and we mixed exact molar ratios of the normal regimens, so the FOLFIRINOX and gemcitabine nab-paclitaxel, and we combined them with the tigecycline. So basically, they showed that it works, and we extended this work to actually regimens that are given to people, because gemcitabine alone is not used. It's always used in combination.
Thank you, Dr. Madhu. Is there anyone else who would like to ask a question? Thank you, Doctor. Our next poster presenter is Dr. Svetlana Ilarionova, head of BINAI lab of Caltech from Russia. She will present benchmarking generative models for virtual staining from HNE to IHC translation in histopathology. Kindly join me in welcoming her.
Thank you. Can you hear me now and see the presentation?
Yes, we can.
Thank you. Dear colleagues, it's a great pleasure to be here and present our current work. I'm the head of research group at Caltech, and today I'm excited to share our recent results on benchmarking generative models in virtual staining. So one of the central challenges in digital medicine is acquiring high-quality informative data. This process is often limited by labor-intensive protocols, costly reagents, and time-consuming staining procedures. Generative AI algorithms offer compelling solutions for this problem. Across many domains, these models can enhance image quality, remove artifacts, or synthesize new training samples for our models. In histopathology, we focus on virtual staining, transforming routine hematoxylin and eosin slides into immunohistochemistry stains. While H&E reveals general tissue structure and morphology, IHC is essential for treatment decisions such as assessing HER2 or ER2 status. However, IHC is expensive and slow. Recent studies suggest that AI could reduce cost nearly 100-fold and cut analysis time from days to under 1 hour. That is promise we are pursuing. So our project aims to develop AI-based generative models that take an H&E slide as input and output a synthetic IHC slide for specific biomarkers. Key requirements are the following. We want to preserve cell morphology, ensure biological plausibility, and maintaining robustness across different data sources. To support these goals, we built a private data set from 200 patients with breast cancer, each with 3 whole slide images, H&E, HER2, IHC, and ER-IHC. All acquired at 40 magnification, and let's consider algorithms that we use in this study. Generative models for virtual staining can be grouped into 3 main categories based on supervision. The first one is supervised models, such as PIX2PIX and other similar architectures that require perfectly aligned images for model training. So we need the perfect alignment between the main stain and the target stain. But as we can see in practice, it's really difficult to obtain such data. Another possible type of task is unsupervised methods that mean that we work with unpaired data, but we have some biological constraints. And finally, the third option is weakly supervised methods that strike a balance by using limited alignment cues. Each has trade-offs in terms of alignment accuracy, biological fidelity, and generalization. Let's consider in more details generative adversarial network and image-to-image diffusion model. So GANs offer fast inference, but suffer from unstable training mode, collapse, and sometimes limited morphological fidelity. On the other hand, diffusion models provide more stable training and better coverage of the data distribution, preserving fine morphology in our tissue datasets. However, they are computationally expensive at inference time. In our work, we evaluate both families to understand where each excels in the medical imaging context. Now let's consider publicly available data sets for this virtual staining task. We evaluate 2 data sets, breast cancer immunohistochemical data set and multi-IHC stain translation. For the first data set, there were provided 50 paired whole slide images with 2 types of staining. And for the mixed data set, we consider larger amount of data with 4 markers, but limited to patch level data without whole slide variability that can be valuable for real applications. And so these limitations motivated us to build our own data set. And when we design and collect our private data set, we face 2 main challenges. Let's discuss them. AI model quality is highly dependent on data alignment. Therefore, for our private data set, we perform registration and filtration of data to provide high quality paired samples for model training. On test examples, median registration error was calculated and suggest a high quality alignment pairs worth considering. And Therefore, for our final experiments, we achieve samples with high quality. And here you can see our current results, the comparison of different GAN-based models on open source data set, and visualization for our private data set. So we benchmark several GAN-based models and diffusion-based models. And on our private data set, the highest quality is PSNR 18, SCM 0.39, and as the metrics for open data sets are also presented. Here you can see the model performance for different samples from open data set. On the MIST dataset, the best GAN-based models were TDIC stain and PSP stain. Their success comes from integrating domain knowledge such as nuclear density, membrane intensity, and tumor prototypes, which encourage generation in biological reality. And interestingly, diffusion models are underperformed on MIST, like dual limited patch context and registration artifacts in these tasks. So what have we learned from our current study? First, the domain integration is critical. Generic image translation is insufficient for clinical tasks. Future models must incorporate expert-derived constraints to achieve more robust synthesized data. Second, diffusion models have untapped potential. To close the performance gap, we need larger patch size, longer training, and better registration. And we work on these problems. We also develop our own metrics to assess the quality of data, to perform more reliable process of data collection and filtration. Our future work includes scaling the diffusion model, incorporating more biologically based features and information for generation, and validating on whole slide images. Thank you for attention. We believe that virtual staining can transform pathology workflows, and we are actively seeking collaboration in data sharing, artificial intelligence experiment, and clinical validation. Thank you for attention.
Thank you, Dr. Svetlana. Is there anyone who would like to ask a question?
Hi, actually, I have a question, if you don't mind. So I see your research it's mostly centered around breast cancer. So has your research extended to tissues from other organs as well?
Yes, we have other projects with different pathologies. So here we present just one of our research topic.
Thank you.
Thank you, Dr. Svetlana. We are now taking a 60-minute lunch break. Please be back on that. Thank you.
Good afternoon, everyone. I'm Sabrina, one of the doctors from the UK, and I'll be leading this afternoon's sessions. So I hope everyone's had a lovely lunch, and we're back now for the second half of our programme. I'd like to begin to introduce our next speaker, who's Dr. Skander Chowdhury. He's a consultant histopathologist at Northampton Hospital, who will be joining us from the UK, and he will present on appraisal of major IMS and LMIS providers in the digital pathology marketplace. Kindly join me in welcoming him.
Thank you very much for the introduction. Is my PowerPoint visible?
Yes.
Fantastic. I'll just make it full screen. Great. So yes, I'm a consultant pathologist working in this space for the last 25 years, and there's been a major shift in a glass slide to digital pathology within the UK, and I'd like to share with you some of the challenges that have been faced in that transition and what's available on the market. So this is just a summary of digital pathology as a solution. The endeavour is to go fully digital in the UK, reporting 100% of cases digitally. There's a huge amount of NHS funding to support this, and very few departments are fully 100% digital, but many are working towards that. Our flagship hospital, St James's in Leeds, has been fully digital for a number of years, and other hospitals are moving in that direction. The value of digital pathology is more than just reporting, second opinion outside a network, interoperability between multiple sites, particularly for pan-regional MDTs, integrating existing LIMS systems and scanners, and then improving communication across networks through sharing of images, and then leveraging AI interfaces. So I think you'll all be very familiar with the standard end-to-end solution. Cases come in through a laboratory, which interfaces with the local LIMS system. Specimens are tracked, and then images are scanned, reports are generated, and then they're returned back through the LIMS system into the EPR system. So an end-to-end solution, extraction of data from a number of different interfaces, handling different types of data and data formats, central repository, so store and protect data, typically cloud solutions, but also on-prem, and then finally accessing that data through LIMS and IMS software. It's important before we go into the IMS and LIS systems to know that IMS systems are driven by a lot of the scanner vendors, Perio, Leica, Hamamatsu, Philips, all have their own IMS systems, and often they're the solution of choice when it comes to use of the scanner with the IMS. So to talk about some of the scanner profiles, names that you'll be very familiar with, 3D Histech have a P1000 and have been in the market for a number of years, are deployed in large hospital settings with a high throughput of slides. Hamamatsu have their Nanozoomer series and can again take up to a significant number of slides, up to 360 on the Nanozoomer S360, but less than what is covered by the P1000. Then other kind of less well-known names in the market, so Huron Digital Pathology, and again providing a scanner platform with IMS. Leica took over Aperio and are a leader in the market, have FDA clearance on their scanners, and have an IMS system as well. The other big players, Microscan, Roche, Sakura, UniC, Zeiss, all provide scanners in the market with variable penetration. Philips was probably one of the early adopters, one of the early entry into the market, has kind of fallen a little in terms of market penetration with other companies coming into the fore, but still stands as a major player within the scanner market, and it has its own IMS system. Its proprietary format is iSyntax, and it has most recently allowed open source access to reading the iSyntax, as people have now adopted a wider range of IMS systems. To connect to an IMS, you generally need a LIMS system. Typically, this modulates workflow, reporting, laboratory operations. In the NHS, the legacy systems that dominate the NHS, and therefore integration challenges occur with IMS systems. These are some of the key players: WinPath, reliable but legacy; Telepath, a network now has network capability, and probably is one of the bigger players in the market. Epic Beaker is new on the market, fully integrated but a costly system. Copath, structured but rigid, and then MediLIMS, modern and cloud-based. So for IMS, you've got whole slide image scanning supporting the reporting and AI functions, and you have a high infrastructure and storage demands. On the IMS side, I've given you a brief overview, but essentially the main IMS systems are Philips, which is clinically validated, Leica, which is a market leader, Sectra have enterprise imaging. And I think Sectra is an interesting one because being from the PACS environment, it already has built out the infrastructure storage elements of any image system, and then it's now overlaying that with the viewer and linking that to AI systems. So in terms of growth, Sectra is in a very strong position because across the US, in fact, across the world, Sectra is already set up to manage images. So whole networks in the UK have taken on Sectra because contracts are already in place for the PAC systems, and now you're bolting on digital systems. So to a trust, they don't have to manage the storage because storage is already managed by Sectra. And Sectra have data centers in the UK as well. As you know, Sectra are also well established because they have very strong security systems, and they have a separate security arm to their business. And during the time of malware cyber attack on the NHS, they called upon Sectra to provide some security consultancy, given their place in the market. Proscia, AI-driven future platform, and Hamamatsu with strong scanning capabilities, but haven't really focused much on their IMS system. And what you'll find out that the viewers don't necessarily need FDA approval, because of the scanners need approval, but not necessarily the IMS systems. And so the focus of some of these companies has been purely on hardware. So in my appraisal, one of the key challenges, LIMS and IMS are often separate systems, and we've got legacy systems within the NHS, and to integrate with IMS systems is not straightforward, and it's generally not a single sign-on solution with transferable data between the two systems. Often they require HL7, FHIR, and DICOM formats, but the key difference is that one is patient-centered and the other one is image-centered. And now more and more IMS systems are bringing modules out that are patient-centered with patient demographics. But in histopathology, as you know, the reality is you need to be able to manage the full workflow, including blocks, slides, further work, etc. And that then becomes a challenge to the IMS systems that are not built to feed this data into them. Major bottlenecks in workflows therefore occur due to the challenges between LIMS and IMS integrations. This is just a summary of the Telepath Master Lab IMS systems. And this would be an example of an integration. It's quite hard to see, but I took the example of Epic Beaker. So this would be the flow in the lab. And this is how it would have to link in with the IMS system. So you can see that there would be receiving data into the IMS from the LIMS. Then later in the process, when it comes to the scanning, more data is sent across. And then there's a separate process for reading that data in the IMS. And then that's returned back into the LIMS as a report. And then that goes back to the clinicians. So unfortunately, it's multi-API links that are live links and dynamic links to make the two systems work. Here's just a little bit more detail around the IMS systems. I've spoken about Sectra and its size. In older data now, you can see almost 1,000 employees across 19 countries. Inspirato, which has been taken on by Fuji, has some penetration in the US and also in the UK and some of Western Europe. Corista, again, North American with some scope within Western Europe and Japan, is browser-based and offers tools to generate customized synoptic reports. So kind of sits between an IMS system and a LIMS system. And the final part of my presentation is just to highlight how this capability then links in with AI providers. And there are a few that are now starting to emerge emerge in the markets as kind of leaders in this field. Some of the names you'll be familiar with, so iForia, so that's AI for AI technology, has got a good level of growth and is seen in over 50 countries and has a strong presence in Europe, where it's originated from Helsinki in Finland. IBEX, they have limited algorithms, but their most successful one is prostate. And it's now in over 22 NHS trusts in the UK, and it's used as a pre-screen for the pathologist prior to reading. I think the challenge for NHS here is that the cost per slide is around £5 to £7, and you can imagine the cost therefore to a trust that they have to manage. Indica Labs, very strong presence in the US, 1 or 2 installations in the UK, but also some representation in China, Japan, and Western Europe. their Halo Link image management is their state-of-the-art system that they're now moving into clinical as well as research areas. Page AI, you probably saw the new announcements that they're scaling back on their IMS side, but promoting their AI elements through AI algorithms. And they've got a very interesting one, which is a pan-tumor marker that can be used as a pre-screen for detection of cancer in cases where there, in our hospitals where there is a backlog of work, and therefore pre-screen would help. ProShare, mentioned earlier, that it's best of breed software, has clinical diagnosis and is used in research, and has several modular AI algorithms at hand. Visiopharm has been in the market for some time, and is from Horslem in Denmark, and has presence in over 40 countries, and focuses on both research as well as translational medicine and clinical services. So just to conclude, future digital pathology will require AI-assisted diagnostics in cloud-based platforms that are fully digitized labs. And whilst I think whilst digital has made a great inroad in the UK, there are still huge challenges for it to be fully operational. Thank you for listening.
Thank you, Dr. Skander, for this speech. It's very interesting, especially now with the new advances with the AI and integrating it into work. Does anyone have any questions? If not, Dr. Skander, I've just got one question, if that's all right.
Yeah, of course. Yes, please.
I know you mentioned a couple of different platforms about IMS and LMS, but if you could summarize, how do you think they differ in like functionality and use in different cases?
Yeah, definitely. No, really good question. Essentially, in terms of the different systems, LIMS systems have typically been around to be involved in the reporting aspects of laboratory workflows, and IMS has been essentially focusing on the digital scanning, and that distinction still lies, because the IMS systems have come later in the evolution of kind of digital workflows, the outcome has been that they've been built on modern technologies, whereas a lot of the LIMS systems have been built on code bases that are non-web based and non-cloud based and are not configured for cloud hosting. So there's a massive gap between these legacy systems and what we know and can do now. And some of them, for example, Telepath and WinPath, etc., were really highly successful in the 1980s. So you can now imagine where technology was then, and the web was just starting, and they haven't really transformed in that time because it would be a huge investment for these companies. So you're then sat with two polar opposites in terms of technology.
It needs to advance further then.
Yeah, totally.
Thank you, Dr. Skander. Thank you for your talk.
Okay, thank you so much, and appreciate you inviting me as always. Thank you again. Thank you. Bye.
Thank you. Bye. Our next poster presenter is Dr. Batul Ahmed. She's a pathology resident in LN Medical College from India, and she will present Beyond Inflammation, a histopathological audit of incidental findings in appendectomy specimens.
Am I visible and audible?
We can see your slide, yes.
I'm audible as well?
Yes.
Okay. Good morning, everyone. My name is Dr. Zakir Ahmed, and I will be presenting a seminar on the topic Beyond Inflammation, a histopathological audit of incidental findings in appendectomy specimens. For the introduction, acute appendicitis is the most common surgical emergency worldwide, with appendix being the most frequently encountered specimen by reporting histopathologists. Although acute appendicitis is the most common reason for appendectomy in patients presenting with acute appendicitis-like symptoms, a considerable proportion of appendectomy specimens reveal unusual incidental histopathological findings upon microscopic examination. These incidental pathologies refer to unexpected histological findings detected in appendices removed for suspected acute appendicitis. These lesions are often not suspected clinically or intraoperatively and are diagnosed only after routine H&E. Although the majority of appendectomy specimens show acute inflammatory pathology, a small percentage also reveals neoplastic, infectious, or other unusual lesions. These entities are often under-recognized due to rarity and overlapping clinical presentation with acute appendicitis. And routine H&E is therefore essential because some incidental lesions may require additional treatment or follow-up. Despite the advances in imaging modalities, the diagnosis of acute appendicitis still can't be made with certainty, and histopathological examination remains the gold standard for confirming the diagnosis. The aim was to review and categorize rare incidental pathologies encountered in post-appendectomy specimens in patients with presumptive clinical diagnosis of acute appendicitis, and to assess the clinical impact or the change in post-operative management of such cases. It was a retrospective observational study which was performed at a tertiary care hospital between the duration of January 2025 to December 2025. A total of 90 cases which underwent appendectomy for a clinical presentation consistent with acute appendicitis were taken. Appendectomy specimens from patients of all age groups and genders who were provisionally diagnosed as acute appendicitis were included, and specimens with inadequate tissue or missing histopathological data, or the cases where appendectomy was performed as a part of another surgical procedure, was excluded. This retrospective cross-sectional study involves retrieving the histopathological reports along with slides of appendectomy specimen that exhibited unusual histological features from the archives of the pathology department. We took total 90 appendectomy cases which were diagnosed as acute appendicitis clinically. They showed a male predominance. 46 were males and 44 were females with an age range of 7 to 66 years, out of which 12 incidental pathologies, out of which 12 cases shows incidental pathologies. Rest 78 were labeled as appendicitis, which were later then subcategorized as acute appendicitis plus periappendicitis, subacute appendicitis, suppurative appendicitis, chronic recurrent appendicitis, and acute appendicitis with perforation. As you can see, the most common diagnosis was acute appendicitis, showing 43 cases, followed by acute appendicitis plus periappendicitis, followed by subacute appendicitis, which were 10 cases. Then followed by acute appendicitis plus periappendicitis, which were 8 cases, and then suppurative appendicitis, which were 6 cases. 3 cases of chronic recurrent appendicitis and 4 cases of acute appendicitis with perforation were also listed. The incidental finding showed a range of pathology, right from inflammatory lesions to parasitic granulomatous lesions to neoplasms and benign lesions like lipomatosis of appendix, follicular hyperplasia of appendix, or fibrous obliteration of appendix. We found 4 neoplastic cases. WHO has classified appendiceal neoplasm into 2 categories, epithelial and non-epithelial categories. Epithelial tumors encompass serrated lesions, polyps, mucinous neoplasms, and adenocarcinoma. And non-epithelial neoplasm is predominantly represented by neuroendocrine tumors. So in our case, we found 4 neoplastic cases, out of which one was neuroendocrine tumor and the other 3 was low-grade appendiceal neoplasm. This is a table discussing about the management and outcome of incidental lesions, which I will be discussing along with discussion. In the present study, 90 appendectomy specimens were examined, out of which 82.4% demonstrated inflammatory pathology. This is comparable to most studies which also noted inflammatory pathology as the predominant finding in appendectomy specimens. The incidental or unusual histopathological findings were identified in 12 cases, which was 13.3% in our study. The incidence is slightly higher than reported in some larger studies. These variations may be attributed to differences in study population, sample size, or geographic prevalence of infectious diseases. Neoplastic lesions were identified to be 4.4% of the cases in the present study, including low-grade appendiceal mucinous neoplasm and neuroendocrine tumor. The proportion is again slightly higher compared to 1.57% incidence of appendiceal neoplasm reported by other studies in their histopathological analysis of appendectomy specimens, owing to the change to the sample size variability and duration. Now I have discussed only the most important incidental pathologies. First is appendiceal mucinous neoplasm. They have variable malignant potential and their treatment strategies vary depending upon the tumor stage and grade. For low-grade tumors, early surgical resection of the primary site is enough, but in advanced stages, a peritoneal debulking combined with hyperthermic intraperitoneal chemotherapy is advised. When it comes to neuroendocrine tumors are identified incidentally and they are asymptomatic and are generally non-aggressive. They have good prognosis. It is usually less than 2 centimeters in size and is located in the distal 1/3 of the appendiceal tip. Mostly they are graded as G1 and G2 histologically and are positive for neuroendocrine markers. Appendectomy alone is sufficient for tumors that are less than 2 centimeters, while right hemicolectomy is recommended for lesions that are more than 2 centimeters, or whether they are graded as G3 or the tumor has positive margin. Although most NETs are clinically indolent, all appendectomy cases should be screened for their malignant potential. Recommended grossing methods involves bivalving the tip and submitting both halves for microscopic examination. Amoebic appendicitis. Amoebiasis caused by Entamoeba histolytica presents a multitude of ways, ranging from asymptomatic disease to pathological effects on the colon or liver. Entamoeba histolytica can incite appendicitis through the invasion of the appendiceal wall, obstructing its lumen. To call it a true amoebicitis, the Entamoeba histolytica invasion should be seen in the appendiceal wall, in addition to the intraluminal obstruction. Acute appendicitis of parasitic origin is rare, with Entamoeba histolytica accounting for an incidence of 0.5 to 2.3%, which is lower than our study, which is 3.3%. The presentation of amoebic appendicitis is no different than appendicitis of non-amoebic origin, making it difficult to distinguish before pathologic evaluation. Complications like perforation, liver abscess, abdominal sepsis, they all increase the risk of mortality and morbidity in these cases. Usually, the antihelminthic therapy is given, but it is advised that appendectomy is performed as results from systemic review of global cases do not support pharmaceutical drug management of acute appendicitis. Early surgical intervention may prevent morbidity. Endometriosis of appendix. Endometriosis of appendix may be rare and may present with acute or chronic abdominal pain or infertility. Their preoperative diagnosis is difficult as it may present as appendicitis or mucocele of appendix or appendicular mass that may mimic neoplasm. The definitive diagnosis is usually established following histopathological examination of the appendix. The recommended management of endometriosis of appendix is an appendectomy with a gynecological follow-up post-operatively. Diagnosis of endometriosis was made in our study was made in just one case in the present study, in contrast to Gustafson et al., who studied 133 females and found endometriosis to be present in 4 cases. Tuberculosis of the appendix. Incidence of this rare condition has been reported as 0.1 to 0.3% in Western countries and as 1.3% to 2.3% in underdeveloped countries. Systemic conditions such as Crohn's disease, sarcoidosis may be associated with granulomatous inflammation of the appendix. But in an Indian setting, the most likely cause for granulomatous lesion of the appendix is it's highly likely to be tuberculosis. It requires a comprehensive systemic workup, which includes chest X-ray, gene expert, and HIV screening, along with initiation of systemic antitubercular therapy to prevent complications such as fecal fistula, intestinal obstruction, or disseminated tuberculosis. This is a table showing comparative analysis of appendiceal neoplasms between the present study and previously published studies. In our study, the proportion was slightly statistically higher owing to the smaller sample size and the tertiary care referral basis. And now, what's new? As I already discussed, that diagnosing neoplasm is very important as it may change the course of the treatment in patients. So a multi-center retrospective cohort study was conducted across 6 tertiary hospitals in Ankara, Turkey, between January 2019 to December 2024. And adult patients aged more than 40 who underwent appendectomy with preoperative contrast enhanced CT and had available lab data were included. They took note of 5 parameters, which were age, gender, appendix diameter on CT, absence of wall contrast enhancement, and neutrophil count. And each of these parameters were allotted a score of 1, and total score ranged from 0 to 5. So their primary aim was to develop and validate a novel 5-parameter scoring system to improve preoperative prediction of incidental appendiceal neoplasms in patients aged more than 40 years. This study is one of the first large-scale attempts at doing this. And when a score of 3 or more than 3 was used to predict the risk of neoplasia, the sensitivity was 56.6% and the specificity was 65.4%. The positive predictive value came out to be 9%, while the negative predictive value came out to be 96.1%, which indicated that the proposed model may serve as a reliable adjunct to stratify patients into low and high risk groups. In case anybody wants to refer to this paper or article, the reference has been given below. Now, what are the key recommendations for pathologists and for surgeons? One is routine versus selective policy. Studies show that surgeons fail to recognize incidental neoplasms in majority of the cases intraoperatively, while selective policies may save costs. They miss an estimated 1.01 per 1,000 clinically significant neoplasms that require further surgery or oncology follow-up. Every appendectomy that has been performed, which was labeled as acute appendicitis clinically, should be sent for histopathological examination, and a selective policy should not be used. Risk stratified preoperative assessment. You incorporate the 2026 5-parameter scoring system into your hospital surgical pathway to identify high risk for neoplasm. Specific pathological management plan. When an incidental finding is reported, follow standardized management. What is pathology without few beautiful pictures? So here is the section of the appendix showing, this is the section showing low-grade appendiceal mucinous neoplasm. This is the, as you can see, the pools of mucin involving the serosal layer, and in these pools, you can find floating tumor cells with a high MC ratio. This is a section of appendix showing a well-circumscribed submucosal tumor in the appendix composed of nests and trabeculae of uniform cells. These tumor cells show a characteristic salt and pepper chromatin as shown in the inset. This is the H&E section of amoebic appendicitis. I have shown you the amoebic trophocytes, and you can see below that is the degenerated or the shedded appendiceal lining. This is an H&E section showing granuloma. That you can see a very well-formed granuloma lined by a collar of lymphocytes, and the red arrow is pointing towards the Langhans giant cells. And this is the section of an appendix showing complete obliteration of appendiceal lumen by fibrocollagenous tissue with loss of normal mucosal architecture. And this is a section of an appendix showing a reactive follicular hyperplasia with prominent germinal centers. I have marked the lymphoid follicles with germinal centers for you to note. To conclude, the incidence of incidental appendiceal lesions in the present study was 13.3%, which was higher than most published series. The higher proportion of neoplastic lesions, such as low-grade appendiceal neoplasm, may be attributed to the smaller sample size and tertiary care referral bias. Nevertheless, the spectrum of lesions observed is consistent with previously published studies, reinforcing the importance of routine histopathological examination. Thank you very much. Thank you for listening.
Thank you, Dr. Batul, for this presentation. I really enjoyed the images at the end with the different appendicitis. Does anyone have any questions? No? Okay. I was just going to ask Dr. Batul, do you think, in your opinion, that routine histopathological examination should be mandatory for all appendix? Like, I know you said it at the end, but in your opinion, do you think it should be mandatory?
It should be. It should be. The incidence right now of diagnosing appendiceal neoplasms is around 2%. It may be because we're missing few things. It may be because we were not looking at every appendix because the surgeons have labeled it as acute appendicitis clinically, and they're not sending it for histopathological examination.
Okay.
This is something that I'm telling in my tertiary care hospital. I don't know if it's followed in UK or anywhere else, but this is here we practice a selective policy, like because it also depends on the economic status of the patient, whether he can afford a histopathological test or not. So according to me, every appendix should be sent to diagnose. Even label it as acute appendicitis. I think every appendix should be screened because they might hide incidental pathologies that we do not know of.
Perfect. Thank you so much, Dr. Batul.
Thank you.
Next person we've got is Dr. Maria Petova. She's a biologist researcher in clinical laboratory diagnostics in the Moscow Clinical Scientific Center in Russia, and she'll present on role of immunocytochemicals tests in cytological diagnostics.
Hello, dear colleague, dear chairperson. Thank you for introduction. And I would like to present my topic, which called role of immunocytochemical testing in cytological diagnostics. Okay. In the modern era of evidence-based medicine, immunocytochemical studies have become an obligatory diagnostic tool for any oncological institution. And it is impossible to do without immunocytochemical studies in all those cases in order to specify their source of metastasis in metachronous cancers, identifying the primary focus in the presence of fusion without detection primary focus. And a lot of clinician expectation that immunocytochemical study it's something like this. Yes, it's something magical. But all cytopathologists know that it's a little bit different situation in immunocytochemical study. In reality, it's very difficult for identify some cells and for understanding the primary focus, and it's a really difficult tool for all cytopathologists. We need to select in an immunocytochemical panel, and for it we need to differential diagnosis. Our differential diagnosis should be based on cytomorphology, clinical information, age group, and anatomical features. The presence of highly specific markers, and the differential diagnosis should be narrowed of a possible two 3 nosologies. And we have some special, in our institution, we have some special algorithm for immunocytochemical studies. At first, we need to estimate morphological pictures. We need to have clinical information and clinical diagnosis. And we need our differential morphology diagnostics, and selecting a diagnostic panel. And only in the end we need to final interpretation. Of course, they have some problems, some difficulties of immunocytochemical study because we don't have we have a lack of standardization. We need to have a lack of standardization. The absence of reference samples, and a small volume of samples, and lack of validation. Our preparation could be absolutely different. Our sample preparation, we have some ways for prepare our sample for immunocytochemical studies. It can be cell block, liquid-based cytology, sure path, or thin prep, immunocytofuge preparation, for example, cytospin preparation, and conventional preparation, and in some cases we called it traditional SMARS. You can here you can see how look traditional. At first, it's a traditional material. It's conventional preparation. Second, it's a cell block, and here you can see liquid-based shoe path way preparation. What I can say about cell block? Of course, it's better way for preparing our SMARS, our preparation, our material, because we can achieving of material. We have a possibility of obtaining additional material for molecular genetic and for our immunocytochemistry study. We can use immunohistochemical protocols. We can and these protocols standardize, but our immunocytochemical protocols not only for one test, Syntec plus test. and it's easy obtaining of control materials. If we use liquid-based cytology, it's absolutely different because control preparation, we need to have a good control preparation, and we don't have special control preparation like, for example, in immunohistochemical studies. This preparation can be prepared following some technique, like our material, contain sufficient numbers of cells, and need this preparation can be have a strong expression, good expression. And now I talk a little bit about our experience. This study was conducted at our center, Moscow Clinical Scientific Center, in 2024. A total of 236 cases were examined using both liquid-based cytology and cell block at sample preparation method. And dependent on the goal, on the aim, for example, identify primary focus or confirming spread. In immunocytochemical, we selected immunocytochemical panel, and report was made based on the analysis of the research result. In our study, a total of 236 cases were examined, including 164 cases of peritoneal washings, and different group was 2% cases of thyroid gland, 18 cases of EUS FNA material. It was pancreas material and pancreas lesion material, and 14 cases of lymph node, and 36 cases of effusion. And we use cell block method only in 13%, and liquid-based on the 18.6%, and for when we use cell block method, it was for liquid for for our peritoneal washings material and for effusion, and only in little material for different localization, our localization. In the conclusion, I would like to say that in the case of effusion, the preferred method of simple preparation in cell block method as an acquired cellular sample categories, a high quality material for examination examination panel, which is often necessary for those localization. And this method also allowed working according in histological protocols, and in the case of fine needle aspiration, liquid-based techniques, we prefer liquid-based technique, like method of choice due to interference cellularity. In such cases, it is necessary use external controls and validate the protocols for cytological material. And of course, it's more difficulty. When above conditions are met, the informatives of immunocytochemical studies in our center, cytological diagnosis is 98%. Thank you for your attention. Here you can see my colleague who helped me in this work.
Thank you, Dr. Maria, for this talk. It was quite interesting to see the new advances. Does anyone have any questions? No. I've just got one, Dr. Maria. How do you think with these cell blocks that it complements the conventional cytological techniques that we use now?
We think it's, of course, thank you for your question. We think we use, if we have a material for cell block, of course we prefer a cell block method, and we think it's better technique. I said it's we use it in fusion, in peritoneal washings, in all cases when we have good material, cellularity material. Only if we don't have this material in fine needle aspiration cases, we use a different technique. And if you don't have cellularity material, you don't have it. It is what it is. But I agree, of course, a better method is cell block. And we prefer, like I think all pathologists to use this method.
Yeah, thank you.
Thank you.
Our next speaker is Dr. Noskova Karina, and it's my pleasure to welcome her onto the platform. And she'll be presenting on cytological differential diagnosis of malignant pancreatic neoplasms using EUS FNA material.
Не могу включить демонстрацию экрана. Пока все включено? Нет, я не вижу. Включено? Вот так, что ли, надо, да?
We can see you, Dr. Karina, and we can see your slides.
One moment, sorry.
No worries.
Вот так, да? Не получается. Ну-ка,
Hello, dear colleague. Can you see our screen?
Yes.
Thank you.
Okay, thank you. Good afternoon, dear colleagues. I am grateful for the invitation and the opportunity to share our experience. My report presents the 8-year experience of the Loginov Moscow Clinical Scientific Center in the cytomorphological diagnosis of pancreatic malignancies based on endoscopic ultrasound-guided fine needle aspiration. To begin with, I want to say I have no relevant financial relationships to discuss. The relevance is driven by the fact that pancreatic cancer is characterized by high mortality. 5 years survival remains low, not exceeding 10%. Besides, in 3 years, the incidence in people under 50 has increased. All these factors highlight the need to improve effective preparative methods for diagnostic verification. EUS FNA is currently the gold standard of obtaining cellular material from solid pancreatic lesions. However, the final diagnostic depends not only on the quality of a biopsy specimen, but also on the accuracy of cytomorphological interpretation. Cytological analysis of fine needle aspiration remains a currently important step that determines patient's management, ranging from surgical intervention and active surveillance. To standardize protocol in 2022, the World Health Organization introduced a terminology system for pancreatic biliary cytopathology. In our presentation, we focus on the seventh category and the potential for differential diagnosis of malignant pancreatic neoplasm. We reviewed 1,658 confirmed EUSFNA cases of solid pancreatic lesion from 2080 to 2025. Malignancy totaled 1,416. You can see here distribution by tumor types. Ductal adenocarcinoma is 91.3. Neuroendocrine tumor is 4.6%. Solid pseudopapillary neoplasm 1.3%. Metastasis 2.3%. Lymphoma is 0.5%. We used traditional and liquid-based cytology. Immunohistochemistry was performed on cytospin for ambiguous suspected metastatic cases. Our aim is to access the diagnostic accuracy of comprehensive cytology with ICC for solid pancreatic tumors. In all cases, we used rapid on-site evaluation or ROSE. This slide shows our multidisciplinary team, our sonographer, surgeon, and cytologist discussing a clinical case. The application of ROSE increases the diagnostic yield of the bench, reduces the time of diagnostic and staging, and leverages the experience of multidisciplinary team. Now, let me present a clinical case from our practice that illustrates the challenge of different cytological diagnosis of a pancreatic lesion. The patient is a 60-year-old male. His medical history includes renal cell carcinoma, diagnosed in 2015, and colorectal cancer diagnosed in 2017. In 2024, a pancreatic head mass was identified. EUSFNA was performed. Cytological examination revealed loose cluster of tumor cells with mild nuclear pleomorphism and abundant partially vacuolated cytoplasm. To determine the tumor histotype, we performed immunohistochemistry with antibodies to RCC and CD10. Strong expression of these markers confirm that this is metastatic of clear cell renal carcinoma to the pancreas. Now, let me present another clinical case. This is a 26-year-old woman with no symptoms. A pancreatic tail mass was found incidentally on ultrasound. Radiologically, it was thought to be most likely a serous cystadenoma. A EUSFNA was performed. The cytological preparation revealed small SNR and rosette-like clusters of monomorphic tumor cells with mild anosinonucleosis and finely granular chromatin. Pseudopapillary structure were also observed. Immunochemistry was performed to determine the histotype. Immunohistochemistry showed expression of beta-catenin and progesterone in the tumor cells, which confirms the diagnosis of solid pseudopapillary neoplasm. The clinical cases illustrate that we can not only confirm malignancy, but also accurately determine the tumor histotype. And this is crucial for treatment decisions. Now, on this slide, you see diagnostic accuracy of our combined cytological approach in the differential diagnosis of malignant pancreatic tumors. Our findings clearly demonstrate the superiority of the combined method. In conclusion, I want to thank our team for their contribution to this work, and thank you for your attention.
Thank you, Dr. Karina, for this talk, especially with the cases as well, the examples that you've given. It was very interesting. Does anyone have any? I've just got one, Dr. Karina, if that's all right. I know you talked about it at the end, you were talking about the different techniques, but in your opinion, how do these techniques improve diagnostic accuracy in the samples for the pancreatic neoplasms?
Okay, thank you for asking. I think first technique and traditional cytologic because using rows, repeated site evaluation, and two-step and liquid-based cytological cell block and two.
Perfect. Thank you so much. Thank you for joining us.
Thank you. Thank you so much.
Our next is a poster presentation by Dr. Sanya Aurora. She's an oncology fellow from the London Clinic, and she will present on structured integration of tarlatamab in routine thoracic oncology, a risk-stratified monitoring pathway with demonstrable service optimization. Welcome, Dr. Aurora.
Hi, thank you for the introduction. I'll just share my screen 1 second. Is that okay now?
Yes, that's perfect.
Okay, perfect. Thanks. Right. So I will be talking about structured integration of tarlatamab in routine thoracic oncology practice. The question I want to address is an eminently practical one. We're at a point where tarlatamab has transitioned from controlled setting of a clinical trial into the far more heterogeneous landscape of routine clinical practice. With that transition comes a challenge the trials were never designed to resolve. How do you organize safe delivery efficiently and reproducibly within a routine thoracic oncology service? So tarlatamab is a bispecific T-cell engager, a DLL3-directed CD3 engaging immunotherapy that facilitates cytotoxic T-cell mediated lysis of DLL3 expressing small cell lung cancer cells. DLL3 is expressed on the surface of over 80% of small cell lung cancer tumors, but is largely absent from normal tissue, making it a compelling therapeutic target. The Delphi 304 demonstrated a median overall survival of 13.6 months with tarlatamab versus 8.3 months with chemotherapy alone. That is a 40% reduction in the risk of death. Now, with that approval comes an operational imperative. The drug is delivered via a step-up dosing schedule. The approach is designed to attenuate activation and mitigate the risk of toxicity, but it mandates close clinical surveillance for two specific adverse events: the cytokine release syndrome, which arises from the systemic inflammatory response triggered when T cells engage DLL3 expressing tumor cells, and immune effector cell-associated neurotoxicity syndrome, ICANS, which reflects neurological involvement from the same immune activation. The real-world literature is growing, but what has remained less well described is the operational framework, the infusion-to-discharge pathway that makes delivery not just safe, but sustainable across different clinical settings. Now, how often should observations be taken? What are the escalation criteria? How do you position rescue medications? When can the monitoring windows be shortened, and on what basis? So this gap is what motivated our work. Our study design, it's a descriptive single-center consecutive cohort study. It was conducted at the London Clinic. We are clear from the outset about the scope and limitations of this work. There's 6 patients, 26 administrations. We don't make inferential statistical complaints. What we present is a proof of concept, a descriptive analysis that a structured risk-stratified monitoring pathway can be operationalized safely and sustainably in a genuine real-world thoracic oncology setting. Our monitoring regimen was architectured around the step-up dosing schedule. So cycle 1 day 1 and cycle 1 day 8, the 2 highest risk administrations, patients were admitted for a minimum of 16 hours post-infusion. During these inpatient windows, clinical observations were performed hourly for the first 4 hours, then 2 hourly thereafter, with the frequency escalated in response of any clinical concern. Once daily bloods were drawn at each admission, encompassing inflammatory markers, full blood count, renal and liver function, with additional sampling prompted by clinical indication. From cycle 1 day 15 and cycle 2 day 1, monitoring was reduced to 6 to 8 hours as a structured day case attendance. Cycle 3 and 4 comprised 3 to 4 hours of infusion suite observation, and from cycle 5 onwards, just 2 hours. Critically, this de-escalation was neither automatic nor time-driven. Each reduction in monitoring intensity was earned through demonstrated tolerability at the preceding level. Now, what were our escalation triggers? 3 categories of clinical event triggered immediate escalation review within our pathway. The first one being hemodynamic instability. Any unexplained drop in blood pressure or tachycardia not attributable to an alternative etiology was treated as a CRS signal until proven otherwise. New or increased oxygen requirement above the individual patient's established baseline was coded identically and prompted an immediate clinical response rather than expectant observation. The third trigger would be neurological change. This warrants particular attention in terms of how we operationalized its detection. The ICE assessment was performed at every scheduled observation for every patient throughout the treatment course, irrespective of whether any clinical concern was present. The instrument evaluates orientation in time and place, the ability to name 3 objects, capacity to follow a 2-step command, the ability to write a standard sentence, and serial subtraction by tens from 100. Each assessment takes under 2 minutes and can be reliably administered by a trained nurse. Performing it systematically as a mandatory component of every observation check generates a reproducible, documented, and individually comparable baseline. Any deterioration from the patient's own prior score triggered immediate escalation. This is more than a procedural point. The published real-world literature has documented significant heterogeneity in ICANS ascertainment, with some series relying on clinical impression rather than formal scoring, leading to acknowledged diagnostic uncertainty. This approach standardizes the assessment across shifts and observers and eliminates the ambiguity between true ICANS and confounding conditions such as delirium or metabolic encephalopathy that has been defined as a limitation in the larger published cohorts. So our risk stratified monitoring pathway. The slide depicts the full monitoring trajectory across the treatment course. So from the 1 milligram priming dose through to maintenance from cycle 5 onwards. Risk descends progressively as tolerability is established and monitoring intensity decrements in step. The foundational biological premise is temporal concentration of risk. Tarlatamab-related toxicity, CRS in particular, is a step-up phenomenon. It emerges from the novel encounter between the immune system and the DLL3 engaging bispecific, or from its first exposure to the full therapeutic dose. Once that initial immune activation has occurred and resolved without escalation, the probability of recurrence at subsequent equivalent dosing is substantially attenuated. Delphi 304 itself reported CRS in 56% of patients overall, but the events were predominantly confined to the step-up phase and were characterized as primarily grade 1 or 2. The monitoring architecture should therefore reflect that biology. As our results would demonstrate, the biological premise proved correct, and the de-escalation it supports is not a compromise of safety, it's a rational evidence-based response to observed immune kinetics. 6 consecutive patients received 26 administrations of tarlatamab under the pathway. Before turning to the safety data, it is essential to characterize who these patients were, because The clinical complexity of the cohort is the lens through which the outcomes must be interpreted. Delphi 301 enrolled patients with treated, stable, asymptomatic brain mets and required a performance status of 1 or 2. Delphi 304 broadened this to include patients with asymptomatic brain mets, treated or untreated, and brain mets were present in 44% of participants. However, symptomatic CNS disease remained an exclusion criteria in both trials. Patients with significant organ dysfunction, prior severe immune-mediated toxicity, or performance status above 1 were also excluded. The 6 patients we had were substantively different across multiple dimensions. 4 were receiving tarlatamab in the 3rd or 4th line of therapy. 1 had progressed to carboetoposide with atezolizumab, whole brain radiotherapy, a 3rd line rechallenge, and CAV chemotherapy before reaching tarlatamab. 4 of the 6 patients had treated brain mets. 1 patient had a prior durvalumab-induced pneumonitis that responded well to steroids and didn't recur on rechallenge, which was an absolute exclusion from the trial populations. Another had stage 2 chronic kidney disease and a history of hemofiltration following contrast-induced nephropathy. A third carried multiple concurrent risk factors for immune-related toxicity, so diabetes, ischemic heart disease with prior coronary stenting, and borderline liver function tests at baseline. So the histological breadth of the cohort also warrants specific comment. This wasn't purely a small cell lung cancer series. 2 of our 6 patients had high-grade neuroendocrine tumors with confirmed high DLL3 expression, one of probable prostate origin and the other one of probable ovarian origin. Now, this reflects the expanding application of tarlatamab beyond its licensed small cell lung cancer indication into DLL3 expressing tumors that share the biological vulnerability that makes them tractable to this mechanism. The reduction in patient numbers across dose levels, 6 at cycle 1 day 1 and cycle 1 day 8, 5 after that, and cycle 2 and 4 from cycle 3 onwards. This reflects the clinically transparent reasons. 1 patient had documented progressive disease after cycle 1. The patient with high-grade neuroendocrine tumor of the prostate origin discontinued after cycle 1 day 8 in the context of mixed radiological response, significant fatigue, and the grade 2 CRS event at his first dose. So a joint clinical decision was made to stop giving him tarlatamab. But none of these represent pathway failures. For the CRS results, 8 CRS episodes were observed across the 26 administrations, a dose level incidence of 30.8%. Every episode occurred during the step-up phase, 4 at cycle 1 day 1, 4 at cycle 1 day 8. From cycle 1 day 15 onwards, the remaining 14 administrations, there was no CRS. 7 of the 8 events were grade 1, managed with paracetamol, and in 1 case, dexamethasone, and each resolved without escalation. 1 event was grade 2. This was the patient with the high-grade neuroendocrine tumor of probable prostate origin with confirmed DLL3 expression. He developed CRS within 2.5 hours of his first dose with a peak temperature of 39.7 and the oxygen requirement. After structured clinical review, a decision was made to administer tocilizumab on the basis of patient safety. Tocilizumab had been pre-positioned on the ward at a weight-adjusted dose before the infusion commenced and was therefore immediately available. He also received dex and paracetamol. He was managed without escalation to the intensive care unit. So this case encapsulates important operational lessons. The value of pre-positioned rescue therapy, which is the tocilizumab that eliminates pharmacological delay, the necessity of having predefined decision frameworks that enable clinical action. No patients across the cohort required intensive care or high dependency admissions. Eye cancer was identified in 1 patient, the individual receiving tarlatamab in the 2nd line for extensive small cell lung cancer with whole brain radiotherapy treated brain mets and stage 2 chronic kidney disease. The eye score remained 10 out of 10 at every formally conducted assessment throughout his entire treatment course. No treatment was required, no dose escalation was initiated. His neurocognition was intact. In settings where eye cancer ascertainment relies on clinical impression rather than structured scoring, there exists a recognized risk of both underdetection of genuine events and over-attribution of other events. The neurotoxicity preparedness was architectured at multiple levels. We had a consultant neurologist who was briefed prior to each step-up admission and was familiar with each patient's neurological history and baseline before any infusion commenced. So we had active preemptive specialist engagement, not the reactive availability of a neurology referral pathway. The clinic additionally benefits from housing a specialist hematology unit within our building. So the hematology colleagues manage CRS and ICANS regularly in the context of a CAR T-cell therapy. Our intensive care unit was formally notified of every step-up admission as a protocol step with the patient-specific clinical context shared in advance. This meant that any escalation would have commenced from a position of preparedness, not emergency introduction. Median admission duration declined progressively, 72 hours at cycle 1, day 1, 24 hours at cycle 1, day 8, 12 hours at cycle 1, day 15, and same-day discharge from cycle 2 onwards. Now, the 72-hour first admission requires contextualization. This cohort was characterized by significant comorbidity burden and advanced treatment history. The inpatient admission at cycle 1, day 1 served a clinical purpose beyond CRS surveillance. So it encompassed the optimization of concurrent conditions such as glycemic management in patients on steroid immunotherapy, with patients on steroid support, the respiratory review in patients with prior immunotherapy-induced pneumonitis, pain management in those with extensive skeletal disease. In a population of this complexity, the first admission naturally functions as a period of comprehensive clinical stabilization, in addition to toxicity monitoring. The 72-hour figure should be understood in that context rather than as a reflection of the monitoring protocol in isolation. What the progression across the table demonstrates is that once the step-up phase was established and tolerability confirmed, the pathway delivered a sustained and clinically meaningful reduction in inpatient demand. Same-day discharge from cycle 2 onwards from a therapy administered every 2 weeks indefinitely represents a substantial operational shift over the full treatment course. And critically, that transition was achieved without a single CRS event occurring after a patient had left the monitored event. So our pathway performance metrics. There were 4 metrics that characterize the pathway's performance across this cohort. 100% protocol adherence. All 26 administrations followed the pre-specified monitoring framework without deviation. So this speaks directly to the operational feasibility of a structured delivery in routine practice. 100% toxicity capture. All 8 CRS episodes were identified within the monitoring window. 0% high-grade toxicity, no grade 3 or above CRS, no grade 3 or above ICANS, no intensive care or high-dependency admissions across the cohort, and 100% same-day discharges from cycle 2 onwards. Every patient who reached cycle 2 was discharged on the day of their infusion, validating the de-escalation rationale once the step-up phase was complete. This table contextualizes our outcomes against Delphi 301. So I want to reiterate explicitly that this is a descriptive contextualization. With a cohort of 6 patients, direct inferential comparison is neither statistically appropriate nor our intention. Across every domain, any CRS, high-grade CRS, ICANS incidents, high-grade ICANS, and intensive care admissions, the outcomes were consistent with the published trial and the real-world literature. The one entry in the table without a trial comparator is the admission reduction metric, so the progressive decline from 72 hours to same-day discharge. So this represents the distinctive contribution of real-world pathway data to the field and is directly relevant to service planning as tarlatamab volumes continue to grow. The implementation science. So I'll walk you through the operational choreography of the pathway from the beginning of each patient's journey, because the implementation detail is where the durable safety is constructed. Now, before tarlatamab is prescribed, the clinical and logistical groundwork is laid. Educational materials, including multimedia resources provided by the pharmaceutical company, are reviewed by the team. The treating consultant then conducts a structured patient education consultation covering the step-up dosing schedule in detail, the clinical features of CRS and ICANS, the monitoring plan at each cycle, and what the patient should do in the event of symptoms developing after hospital discharge. Ward doctors and our trained oncology nursing staff reinforce this education at each admission. Pharmacy is engaged from the outset. Tocilizumab is ordered, prepared at weight-adjusted dose, and pre-positioned on the ward prior to every step-up infusion. The neurologist is personally briefed on each patient. The ITU is formally notified. On the day of the infusion, monitoring proceeds as described: hourly observations for the first 4 hours, 2 hourly thereafter, structured ICE assessment at each check, once daily bloods. Monitoring is abbreviated at each subsequent cycle, only following demonstrated tolerability at the prior level. So it's risk-informed rather than time-driven. From cycle 2 onwards, the patient attends the same day case. The infrastructure has served its purpose. So the reproducibility element of this slide is not incidental. This pathway exists as a documented, transferable framework. The monitoring thresholds, escalation criteria, pre-positioning protocol, and specialized notification procedures are adoptable at other centers. The relevance of this work extends beyond tarlatamab and beyond small cell lung cancer. So tarlatamab represents the vanguard of a class, not an isolated agent. The Delphi program itself spans multiple settings. So there's Delphi 305, which is evaluating tarlatamab in combination with durvalumab as first-line maintenance following chemoimmunotherapy in extensive-stage small cell lung cancer. And there's Delphi 306 and 312, and they're exploring earlier line integration. The treatment paradigm for small cell lung cancer is evolving rapidly, and tarlatamab is positioned across multiple lines. Simultaneously, analogous bispecific T-cell engager molecules are in development across non-small cell lung cancer and other thoracic malignancies. So this monitoring framework we have operationalized here: risk stratification by dose level, structured neurocognitive assessment at each check, pre-positioned rescue therapy, iterative monitoring de-escalation tied to demonstrated tolerability is not small cell lung cancer specific. Its principles are directly transferable to the next bispecific agent and the one after that. From a resource perspective, the transition to same-day discharge from cycle 2 reframes the capacity calculation for the drug. A therapy that could otherwise occupy an inpatient oncology bed service for 2 weeks indefinitely becomes, from the third administration, an outpatient infusion. For centers without substantial inpatient oncology infrastructure, that distinction determines whether tarlatamab is deliverable at all. For all centers, it represents a meaningful reduction in per patient bed day cost and a proportional improvement in patient quality of life. To conclude, this is a descriptive proof of concept series, 6 patients, 26 administrations, a single center. We are explicit about the limitations that follow from that. What they demonstrate is this: a structured, risk-stratified monitoring pathway that enables the safe delivery of tarlatamab in a genuinely complex, comorbidity-rich, multiply pre-treated population. CRS was confined entirely to step-up dosing, all grade 1 or 2, without high-grade events, without a single intensive care admission. ICANS occurred in 1 patient, was detected through mandatory structured ICE assessment, and required no treatment. Admission duration declined progressively from 72 hours to same-day discharge from cycle 2, which is a measurable and reproducible operational outcome. The framework we have described demands organization and clinical rigor. It doesn't demand disproportionate capacity. So at the clinic, the convergence of a specialist hematology unit, a well-equipped and pre-notified intensive care unit, an active neurological specialist engagement, and a pharmacy model that pre-positions rescue therapy before the infusion commences has allowed us to operationalize this pathway safely without increasing demand on service capacity. Thank you.
Thank you, Dr. Aurora, for this talk. It's very interesting and the results are very convincing as well. I just wanted to ask if anyone's got any questions. I've just got one question. You mentioned, I know the whole talk is about risk stratified monitoring pathway, but in your opinion, how do you think it improves the input of the medication into thoracic oncology? Because it sounds quite thorough, the process that you took.
Do you mean how, sorry, I didn't get that. Do you mean how tarlatamab helps thoracic oncology in its own?
No, how the process of the risk stratif, like the monitoring that you took, how did that help with the process of inputting tarlatamab in thoracic?
So how that helps is, so we're able to identify if there's any adverse event that happens, we're able to identify it off the bat. With that monitoring pathway, what we've done is, especially in cycle 1, when you give the initial dose and then you step it up. So with that, it activates the immune component in your body. So what that does is, with the monitoring pathway, you can identify the risk factors earlier on and treat them as and when required. So it doesn't go on to a high-grade CRS or a high-grade ICANS where you need ITU admissions, you need neurology coming in. So, it's basically avoiding that. And so the patient is still able to get the second cycle of the drug.
Perfect. Thank you so much.
No worries. Thanks.
We've got one more speaker, but we're going to take a 10-minute break. So if you want to grab something to drink or anything, and then we'll come and meet back at 12:40. Sorry, it'll be in 10 minutes for you guys.
Thank you.
No worries.
I still can't do it, so video. Good morning. This is Shalom Masood from United States in Jacksonville, Florida, and I'm sorry for the delay. Our computer was not allowing us to really get connected sooner, but if that is still okay, I'm going to start my presentation. Is that okay? Is there anyone there?
Hi, Dr. Masood. It's Sabrina. It's so lovely to have you.
Thank you.
I think we are ready to start. Would you like me to introduce you?
Yes, please go ahead and do so.
Okay. So thank you all for waiting. It's a great privilege and honor to introduce you as the keynote speaker, Dr. Masood, who's joining us from the United States. She's a globally renowned expert and a highly respected professor and chair of the Department of Pathology and Laboratory Medicine, and she's known for her outstanding contribution to the field. And we are really honored to have her with us today, and she will be doing a talk on the promise of AI in breast pathology.
Good morning, everyone, and thank you for staying. And I know that this is last day of your conference, and I am just sorry that I'm starting so late because of the computer issues that we have had. So, having said that, and thank you for your kind introduction. Having said that, first of all, I just want to tell you that I have no relevant financial or non-financial relationship in this presentation and program. And in that scenario, my plan today is to highlight the challenges associated with the difficult to diagnose cases in pathology, discuss the significance of overdiagnosis and overtreatment, and suggest the potential use of the artificial intelligence to serve as a diagnostic adjunct. First, I'm just going to start with a few facts that you all know that, but to remind us that this discipline of pathology is the study of human illness, and the pathology report is the story of that illness in a given patient. And pathology diagnosis is the foundation of optimal choice of therapy, and false positive and false negative diagnosis can result in under and over treatment. Pathology diagnosis was basically based for many years on gross examination and light microscopy, and the most common diagnosis was undifferentiated malignant neoplasm. Then the emergence of new technologies, molecular characterization of tumors, stratification of patients for therapy based on tumor characteristics, and a paradigm shift in patient care resulted in the fact that pathologists become an integral component of practice of care collectively, and pathology became a component that right now in majority of the breast centers is a major contributor to the treatment planning of the patients. So with the changing role of pathologists, we not only have to establish a diagnosis, we need to classify a neoplasm, differentiate between a primary versus a metastatic tumor, predict the response to therapy, provide a prognosis, and compose a comprehensive pathology report. And aside from that, prognostic factors that is all listed in here, these are the entities that we incorporate in our pathology report, and every single one of these components are participatory in the choice of therapy for that individual patients. So we really carry a significant role in ultimate treatment planning and the outcome of the patients with breast cancer. And of course, prediction of response to therapy based on assessment of the status of expression of hormone receptors, HER2/neu oncogene, and the new genetic molecular pathways. These are all right now participating in the process of pathologist's role to try to really provide more information for better therapy. Current issues in breast pathology include diversity in tissue handling, processing, and reporting, insufficient evidence-based correlation between morphology and patient outcome, significant inter-observer variability in diagnosis and test results, and communication barriers between pathologists and physicians involved in patient care. Currently, there are no uniform guidelines to measure the rate of diagnostic errors. Fear of disclosure and medical legal issues limits the reporting of diagnostic errors. There is limited standardization in breast pathology and biomarker studies, and there are many lookalikes in breast pathology that can mimic cancer. And this is an example of that. The most common component of overdiagnosis and underdiagnosis is atypical ductal hyperplasia versus ductal carcinoma in situ. And when you really look at the definition of this entity, it said an entity which has some, but not all the features of low nuclear grade ductal carcinoma in situ. And you can see with this kind of definition, there are significant opportunity for errors in our diagnosis of this entity in breast pathology, even though clearly we know that entities, they have been diagnosed both in cytopathology as well as surgical pathology. And these are just examples of atypical ductal hyperplasia in the upper level, and then low-grade ductal carcinoma in situ in lower level. Another fact to consider, screening mammography and image-detected biopsy have increased diagnosis of atypical ductal hyperplasia and carcinoma in situ. And since 1988, the incidence of DCIS diagnosis has increased significantly and currently represent 20% of screen-detected cancers. So this is a common problem, is a common diagnostic issue that we have in breast pathology. However, we have recognized that with increase in the diagnosis of ductal carcinoma in situ, the number of invasive breast cancer cases has not decreased. And the distinction between ADH and low-grade ductal carcinoma in situ has remained a diagnostic challenge. And this problem commonly leads to overdiagnosis and overtreatment, which leads to more healthcare expenses and more patient anxiety. And there is evidence suggesting that low-grade DCIS may not need cancer therapy. Therefore, in that setting, we definitely know that there are major differences in the accurate distinction between these two entities and the follow-up management, and it's important to make the distinction between these two entities. And why a second opinion is important? Because studies have shown that the estimated rate of change in surgical therapy following a second opinion is up to 7.5% of cases. And in 40% of cases, additional prognostic information may alter the outcome and the course of follow-up therapy. So what is the significance of this finding? When we really look at over 1.1 million women are diagnosed with breast cancer each year across the globe, even if we look at estimated diagnostic error between 5 to 10% to the lowest level, it appears that a significant number of women will receive under and over treatment. What are the challenges of this practice of breast pathology, especially in low-resource countries? There are limited financial resources, inadequate number of appropriately trained pathologists and technologists, and the differences in a stage of breast cancer presentation. Therefore, we need to raise the bar. And this is a plea for standardization and improved quality of breast pathology across the globe. How do we optimize the practice of breast pathology? We need to improve diagnostic workflow, eliminate human errors, increasing inter-observer reproducibility, and adapting the new technologies. And this is where we get into the practice of what are the technologies that are helping us in breast pathology. We have immunocytochemistry, FISH, quantitative image analysis, next generation sequencing, digital pathology, and at the moment, artificial intelligence have played a role in trying to be a promise in the future diagnostic workup of breast pathology. And of course, for AI to become a part of the practice of breast pathology, the most important driving force is the ability and access to digital pathology. And of course, digital pathology has the capability of capturing the morphological features of breast biopsies, and then through this process, it is naturally easy to diagnose and also send these cases for second opinion to the people that they can help us in proper diagnosis of breast pathology. What are the contribution of AI? Development of machine learning-based models for detection, localization, and segmentation of various breast lesions, detection of atypical lesions in situs and invasive carcinomas, and distinction between atypical hyperplasia and ductal carcinoma in situ. This also can help us in accurate classification of breast lesions that is associated with appropriate patient management. Specific features such as histologic subtype, nuclear grade, presence of mitosis, tumor grade, and the status of microenvironment are very, very important. And by automating these quantitative lesions, AI can reduce inter-observer variability measures. And these are the areas of the investigation and research that many people are right now trying to take a look at it and try to establish a different way of diagnosing breast pathology by the use of AI. Machine learning systems have the capability of quantification of various biomarkers and assessment of mitosis. Certain systems can provide visualization of microscopic classification or microclassifications and metastatic carcinoma of the lymph nodes. AI can contribute to the standardization of breast pathology, can predict patterns from expert annotations and histological data to establish a standardized criteria for accurate diagnosis. And these advances promote inter-observer agreement, reduce errors, and contribute to quality improvement in breast pathology. Ultimately, consequently, AI can provide consistent and reliable measurements, ensuring more accurate staging and treatment decisions, promote significant patient safety measures without increasing turnaround time or case workflow. And this concept is very, very important these days. As you know, there is almost a national shortage of pathologists across the globe. And if we would be able to have something that could help us to try to effectively better diagnose pathology cases, that really is going to be helping incredibly in our ability to be effective in accurate diagnosis of breast pathology and the consequent biomarker assessment. What are the other contributions of artificial intelligence? Prediction of the status of biomarkers, molecular characterization and recurrence risk based on the morphology on H&E stain slide. Multi-model databases can be used to develop predictive models that can assist in treatment decisions and patient outcome. Patients and pathologists in rural areas and in countries of limited resources can benefit from virtual pathologist consult. And again, this is a very, very important part of the practice of pathology across the globe, that since there are limited number of established pathology laboratories and pathologists, this kind of new technology can really play a role in our ability to provide accurate diagnosis in pathology across the globe. Furthermore, providing an accurate diagnosis and second opinion across distant locations are critical steps in improving the quality of patient care across the globe. And this is a very important statement, given the fact that naturally, if we are trying to make an impact on change in mortality rate from breast cancer, we need to make sure that we start with an accurate diagnosis. And we have the capability of not only biopsy, but also ability to diagnose properly. There are still countries in the world that some patients are really losing their breast because of just a fibroadenoma. There is a mass, they cannot diagnose what it is, and then they ultimately end up to try to do mastectomy, which is easier way of trying to really make sure that at least the mass is out. So, having said that, with all of the contribution that artificial intelligence can do in breast pathology, there are challenges associated with this technology, and it truly will take a long time for us to become familiar and become comfortable with this concept as a diagnostic aid for us. One is interpretability. It's not an easy concept. You need to have proper individuals within the system that they do that initial machine learning concept and make sure that that interpretation of the features seen by AI is equivalent to what we really consider as diagnostic criteria. We need to further validate that. Having few articles in the very major academic institution in the country with full-blown support is different from adapting this technology in every pathology laboratory. Regulation, we need to really understand who is really in charge ultimately. Who is going to take responsibility of misdiagnosis initiated by artificial intelligence? And we need to have a concept of make it a process that is generally accepted by everyone. And of course, cost is another component that we need to keep under consideration. So when we look at the promise of artificial intelligence, this is a multi-model approach using proteomics, genomics, and AI-based multiplex biomarker qualifications, and to build a model for establishment of a comprehensive patient-specific tumor precision therapy. So this is practically one of those dreams that we all have, that we would have access to system and people, that they provide us with the ability to use something else to try to help us to make sure that we have the capability of diagnosing large number of cases on a daily basis, but with accuracy and precision that is important in the ultimate therapeutic planning as well as the outcome of the patients with breast cancer. What are the take-home message? The current and emerging technologies in computational pathology continue to progress and play an important role in diagnostic pathology. Serious consideration should be given to appropriate validation, regulatory compliance, and ongoing training of pathologists. Pathologists must consider AI as a diagnostic adjunct and use it as a complementary tool in diagnostic pathology. I do not believe that we are at a stage that we would be able to just, do the digital pathology in all the core biopsies that practically, for example, to come to our department, and based on what we are getting through the AI technology, just provide a diagnosis without having a very intimate and careful supervision and appropriate in participation in the process by pathologists to make sure that no errors are made, because errors in pathology are not permitted. Because every error that we make, it has a direct impact not only on patient care and their outcome, but you have to recognize every patient with breast cancer has a family and their children and the family that have to really suffer if we are making a wrong decision and wrong diagnosis. So we have a major responsibility. And while we can welcome the new technology, we need to make sure that we are in charge, and we need to make sure that we have the capability of incorporating new technology in our practice and yet have total control about the diagnostic accuracy of what we really bring on board. So, last message of mine is AI is just another set of eyes. This is not something that at the moment it could really replace pathologists as the initial individual or the person in charge of making diagnosis. And we have to be very careful in making sure that we are there and we are using this technology appropriately for the process of enhancing our diagnostic ability, increasing our workflow, and then hopefully have a better way of enjoying our role as a breast pathologist. With that, the impact of AI is not only limited to breast and prostate pathology, but is almost all pathologic entities, both in anatomic and clinical pathology. So this is a process that is continuous. That's a process that we need to be associated with and learn about it and make sure that when it is properly approached and we have all the measures in place to try to really bring it as another measure that can help us to better diagnose our patient. And of course, we have a long way to go. So this is not something that is really appropriate to think that this is ready for prime time. This needs more work, validation, and cooperation among researchers and people that they are doing this technology to make sure that every pathologist in the world is familiar with the promise, the challenges, and all of the components associated with this new technology. And with that, I'm going to, practically, say my thank you for allowing me to talk about this entity. And I'm terribly sorry for a delay in my presentation because of the things that it was not under my control. So it was a pleasure to talk to you all, and I'm available if there's a possibility that we can have any conversation about this. And thank you and have a great day.
Thank you, Dr. Masood. It was worth the wait, this talk. It was really interesting, especially the take-home messages.
Thank you.
Does anyone have any questions? I've just got a couple of questions, if that's all right, Dr. Masood.
Sure.
So I think the first one is someone was asking, how does AI assist in detecting and classifying breast lesions?
Classification of what?
Breast lesions.
I don't understand.
So how does the AI help in classifying and detecting the breast lesions?
Well, I think the way that this AI is contributing to the process, first of all, we have to have digital pathology, because digital pathology is going to provide a platform that people that they know how to use AI use that as the measure to try to take a look at different entities, and by a variety of different measures, try to see whether they can identify benign lesions from non-benign lesions. And this is the first step. When they do that, that by itself is really going to be removing a lot of benign breast entities that may not really need a lot of attention to that. I mean, the pathologist can take a look at it very quickly, and with that confidence from AI classified as non-cancer, to become comfortable with that. Then the non-benign cases that are malignant, these are the entities that really is going to be marked as suspicious or non-benign. And then in the identity, pathologists need to take a look at it and see what it is. So at the moment, AI hasn't got to that status of sophistication to try to really bring a specific diagnostic entity there. Still, there are combination of the AI, combination of digital pathology, AI, and the pathologist together to try to bring a adequate and appropriate diagnosis, but it can do it in a much rapid phase than we are doing it right now, because somebody else has already practically, screened the breast pathology, core biopsies. In that setting, things become a little easier for us to try to really pay attention to those cases that they require attention.
And then it's always the pathologist who has the second look of eyes to check that is correct or not.
Yes, the pathologists need to take charge of, because ultimately they are the one responsible for signing a report for that. So legally they're responsible for diagnostic measure. Nobody can really go and say that, okay, I did it with AI, so it is appropriate for me to make a wrong diagnosis. So pathologists are still in charge, and pathologists need to make sure that they understand exactly the challenges associated with AI in diagnostic pathology, but at the same time, what are the benefits that they can use it to speed the workflow and try to have a better outcome as far as the number of cases that they can accurately diagnose.
Perfect. Thank you. And then the second question, I think it might be the same. I think you answered it. It's what is the future potential of AI in breast cancer diagnosis and management?
Well, I think the most important really promise of AI is speed in our workflow. If we would be able, and we're talking about there are laboratories, there are commercial laboratories perhaps that they get about 100 cases of breast biopsies per day. So that if they would be able to look at, 40% of these cases are benign cases. So they're easier to really select those first, see that AI has defined them as non-malignant, and you can take a look at it very quickly and then, establish a diagnosis for them very quickly. The rest of them that they're malignant, or suspicious, those are the ones that we have to really take a look at it ourselves appropriately. Again, AI can also make that distinction between, for example, just suspicious or invasive cancer. We have done a study actually on that AI is really pretty good in making diagnosis of invasive cancer, because invasive cancers, with the pattern that they have, they're easy for AI to distinguish. I think still the areas that require much more attention is on difficult to diagnose cases. Atypical ductal hyperplasia, low-grade DCIS, atypical papilloma, columnar cell change with atypia. Those are the areas that there is a lot more work has to be done in order to try to AI to have that accurate diagnosis. But they can classify them. And when they classify them in a category that is benign versus invasive cancer, that by itself is a great help to try to really increase the workflow.
Okay, good. Thank you so much.
Thank you.
Dr.
Any other question? All right. Did you understand what I was saying?
I think they did. I think they're all stunned.
They're good? Okay. All right. Well, thank you. Thank you very much for this opportunity. And as I indicated, I'm sorry for the, the process of not starting at the right time, but I'm glad that we ultimately got a chance to really have this. And please call upon me if there is any other occasion that I can, help you out or, talk about any other thing in breast pathology that you would like me to do. Okay?
No, that's perfect. Thank you so much for joining.
Okay. Thank you.
Thank you.
Bye. Yes.
So today is the end of our day one, and it's great that we've seen so many talks and so many presentations, and it's been a great learning opportunity for everyone. I thank everyone who's taken part, and also for the organising committee for their efforts in making today's session a great success. We look forward to welcoming you tomorrow as well. It will be 9 o'clock in Dubai time for day 2 session. So thank you everyone, and have a lovely evening or morning.
Okay, thank you. Have a great one. Thank you. Bye.